Hey everybody, welcome to day number 2. Sorry we're getting started a couple of minutes late. Had a couple little technical issues to work out this morning, but I think we're good. So first off, thanks for being here again. Hope yesterday was instructive and helpful and good. So first, let me run through a couple of business items for everybody. First off, the questions and answers. I think yesterday there was a little bit of communication error, or maybe we weren't really clear. But when you ask questions during the panel discussions, or actually any point throughout the symposium, use the live chat that you find underneath the screen, the live stream screen. You can see it question/live chat. The members chat goes to individuals, sort of peer to peer. And so some of the questions were missed yesterday. Our apologies, but we did see them later in the day. So make sure to use that live chat function. Also, the backup stream. I know there was a little glitch there for half a minute where it had a little circle going. That's what the back stream is for. And you can click on that. You shouldn't really lose much time. We're talking about seconds. But we also know there's not a live chat function on that back stream, but the live chat on the first one will still work. So hopefully we won't have that issue at all, but in case you do. Next, please, as we asked you before, find the survey, which is in the main lobby. You'll see a tab for survey. We would love for you to complete that and let us know what you think about the content and the program, etc. Also, there's some downloads, and you'll be able to find in the downloads, for instance, something we talked about yesterday, the SCI consultant in labs. We're asking scientists, and we're also asking community members to sign up for that and let us help you find some matches where we can get some folks connected to SCI research labs. Also, our advocacy toolkit. If you want to find out more about our Cure Advocacy Network and the legislative work we've been doing, we would very much love to have you download that, have a look, and reach out to us and tell us how we might be able to partner together. Lastly, on the business items, again, we are so grateful for our sponsors to be able to bring this event to you. In the exhibit hall, you'll find virtual booths for all the sponsors that have elected to use them. Please go take a visit, look at some of the material they have, and there's an ability to connect with them, chat with them, download some material if you so choose. So please do that. Okay, so let's get on with today's event and content. First off, just a quick aside. I don't know if any of you saw the news, but I did notice a tweet this morning from the Craig H. Nielsen Foundation. 3 folks were awarded a substantial prize, $1 million, for their work and commitment to the SCI community. Longstanding work, Alice Shepard, who is a choreographer and dancer, Wesley Hamilton, and also Kim Anderson, who many of you know and who has presented in this symposium in the past. So congratulations to the 3 of them for longstanding good work on behalf of our community. So today, I just want to give you a brief overview. Again, I hope yesterday was helpful. As I mentioned yesterday, for those of you who weren't here, there really weren't any scientific presentations. It was a lot of contextual stuff, kind of a lot of setup in the hopes that it'll help you think about and think through the scientific presentations today and tomorrow. I hope that made sense to you. What today is, there'll be a session on what we call clinical innovations. So 3 researchers doing some extraordinary research around neuropathic pain, around exercise, and around diet, which in our estimation and in ways challenge some of the conventional ways of thinking about those 3 things, and are very interesting. And I hope we look forward to those presentations and then the conversation to follow. Please check again the program and the abstract so you familiarize yourself with those presentations. That will also be followed by our sexual function session. 3 researchers who have done long-standing work in sexual function with a particular focus on pleasure for the most part, not simply fertility, not to diminish fertility, certainly, but we felt like there's not a lot of focus often on pleasure in terms of sexuality as opposed to fertility. And then in between, or sort of bookending those, will be a conversation with another one of our work groups that we've been working on for the last 3 years is activity-based therapy, activity-based exercise. And we'll have a couple of folks that are responsible for just launching an association of activity-based exercise and therapy centers across the US and Canada. And so we'll have a conversation about that with a kind of, lean into some of the scientific presentation on exercise. And then also one of our Ohio Cure Advocacy Network advocates who was very influential in getting our Ohio bill passed, Jake Beckstrom, our CAN manager, and Pete Noah will have a conversation about that. And Pete now is the co-chair of the advisory council in Ohio that's reviewing proposals for the $3 million legislation that we were able to pass a couple of years back. So that's pretty much the day. And then at the end, Florian Solsbacher from the University of Utah and Blackrock Microsystem, kind of a lean in towards or a nudge towards some of the conversation we'll have tomorrow about neuromodulation. And really we'll talk to Florian about that company, the technology, and also the challenges in creating a sustainable company in this space, not specific necessarily with BlackRock to SCI, but certainly some hold in that space. So that's kind of a quick snapshot of the day. Look forward to the presentations and to our conversations following. And then as per yesterday and last year, there will be 3 breakouts following the live stream, which we'll leave. You'll go to the links in Zoom and we'll have 3 different ones, kind of an open networking and then sexual function and then the clinical innovations panel. So look forward to seeing you and talking with you there. Okay, so here we go. Please welcome Ann van de Winckel, PhD and PT. She's the assistant professor Division of Physical Therapy at the University of Minnesota, and yet another in this session of innovations in clinical treatments, particularly her recent studies on helping to mitigate neuropathic pain after spinal cord injury using some really novel methods. I look forward to hearing her presentation. I hope you enjoy it. Please welcome Dr. Ann van de Winckel.
Good morning. My name is Ann van der Winckel. I'm the director of the Brain Body Mind Laboratory, and I am assistant professor in the Division of Physical Therapy and the Division of Rehabilitation Science. And both are housed in the Department of Rehabilitation Medicine in the Medical School at the University of Minnesota. And today I have the great pleasure of presenting preliminary results of the clinical trial of cognitive multisensory rehabilitation for neuropathic pain relief in adults with spinal cord injury. And this is a study where I am the co-principal investigator with Dr. Leslie Morse, who is the head of the Department of Rehabilitation Medicine. And before I present my data, I want to give a brief overview of brain regions that are important for this talk. So imagine that you're walking in the living room at night because you're thirsty and you want to get some drink in the kitchen. And as you're walking, you're stepping on a toy that your child left behind the evening before. And so the soles of your feet have receptors and send information to the brain about this toy, and the brain identifies pressure, texture, and the shape of that toy. But the brain also tells you where that toy is in relation to your foot, if it is touching your heel or if it's touching your toes, and also where that foot is in relation to the rest of your body. Like, did you just start out that step and you just touched the toy, or did you actually continue to walk and now you have the whole body weight on top of that foot? And so 2 brain areas are very important for this body awareness, and those 2 areas are called the parietal operculum and the insula, and they are circled in purple in the left picture, and they are also in the orange box in the right picture as part of the multimodal integration network. And those two areas that are important for body awareness, so understanding the awareness of the body, they are sending information to the posterior parietal cortex. And there the brain is creating a visual spatial body map. So it's creating a picture, if you want, of your body in space. And it's updating that body map at each moment in time to guide movements. So now imagine the same situation, but your foot is sleeping because you slept funny. So there is reduced sensation in your foot, which means that you don't know exactly how your foot is positioned on the floor when you walk. And also you're not really sure what you feel under your foot. And so you might feel that something's off, or you might feel pain, but the brain might have a hard time identifying what it is that you feel under the foot. And so when you have a spinal cord injury, which is the case for almost 300,000 Americans, there is a reduced or even sometimes complete loss of sensation and movement below the level of the spine injury. And so about half of them have neuropathic pain that severely impacts daily life functioning. And when a person has reduced sensation or a complete loss of sensation, two things happen. First, the brain is expecting to receive normal sensation from all parts of the body, and because that is needed to create that body awareness and also to create that body map. So when sensation is altered, the brain is having a hard time creating that accurate body map and gets confused because the information that it receives from those body parts is not helping. And so they have a hard time creating that picture of the body, especially those parts that have reduced sensation. And so when sensory information is altered, and so different from when the brain is expecting to receive, it gets confused. And you could compare it to a radio channel that is not working properly. So the brain receives a lot of noise and a little bit of sound. So it tends to crank up the volume to listen better. And we believe that that cranking up the volume is the neuropathic pain. And so what is important to know is that those two areas, the parietal operculum and the insula, are not only important for body awareness, but they are also key areas in the whole pain network. So then the next question is, well, knowing that those parts are important for pain perception and body awareness, what is known about their function in adults who have a spinal cord injury? And so prior studies have mainly focused on global changes in brain networks after spinal cord injury. And our research group, Dr. Morse and I, have actually independently found that those areas, parietal operculum and insula, have weakened connections with the rest of the brain in a person who has had a spinal cord injury. And so then the next question would be, okay, so if we know that those connections are weakened, can we restore those connections? And if so, can we reduce then the neuropathic pain and perhaps improve sensory and motor function? And so the answer is yes, with cognitive multisensory rehabilitation, or CMR as an abbreviation. And so prior studies and publications have indicated that CMR can reduce pain in adults with shoulder impingement syndrome and improve movements in adults with stroke. And we did a case study where an adult with cortical blindness and tetraplegia, so paralysis of the forelimbs, improved visual function and sensory and motor function after CMR. And we also did a study in adults with stroke, where the adults with stroke received 6 weeks of therapy, and those adults were 1 to 7 years post-stroke. So they finished their regular therapy. And so we found that they improved in sensory and motor function, and that improvement remained for at least a year because we followed them up that long. And one of those participants also had pain in the shoulder because of subluxation, and that was debilitating pain. It was 10 out of 10, and that reduced to 3 out of 10 after 3 sessions and never got higher than 5 over the remaining of the year. And we also looked at connections in the brain at rest in those adults with stroke. And that is what you can see in a picture. So the top two rows show in orange weakened connections between the parietal opercle limb that was in the injured hemisphere, so the injured part of the brain, with the rest of the body. So all those 34 connections were weaker in adults with stroke compared to healthy adults. And then after the 6 weeks of CMR, so that was 3 times a week, 45 minutes per session, there were only 4 connections that were still weaker in adults with stroke compared to healthy adults. And that's what you see in the bottom 2 rows. And the other 30 connections were strengthened and did not show a difference in strength anymore between adults with stroke compared to healthy adults. So that led us to then ask the question and investigate if CMR could help adults with spinal cord injury for pain and perhaps sensory and motor function. And so that's what we did in a study funded by the medical school. It's called the Academic Investment Research Program. And so we tested and enrolled 25 adults with spinal cord injury and 25 adults without spinal cord injury. And both groups received a baseline testing and questionnaires and an MRI. And then adults with spinal cord injury were divided in 2 groups. So one group, here depicted in green, started with CMR for 6 weeks, 3 times a week, 45 minutes per session. And then we tested them, and then we followed them up for another 6 weeks to see if they improved, if that improvement was maintained when they were at home and did not receive therapy. And then group B, depicted here in off-white, started with 6 weeks of observation at home, and then we tested them again, and then they received the 6 weeks of therapy. And then both groups received a final test, questionnaires and MRI. And the adults with spinal cord injury were also tested on sensation and movements with the ASIA test. And so for that test, sensation was tested with a cotton ball for touch, and with a safety pin to distinguish pinprick from dull sensation, and of course also the location where they felt that. And we also tested strength of the lower legs. And so pain was asked about every week. And so I will show you here first examples of CMR. And so CMR is a physical therapy approach that focuses on restoring body awareness in space of those paralyzed limbs and trunk to reduce neuropathic pain and improve sensory and motor function. And here is one example. So here the participant has her eyes open and she can see the top of her upper legs, but the rest is covered by the cardboard, and she can also see the therapist in front of her sitting, and she can see the shoulder and the upper part of her upper arm, but she cannot see the rest of the arm. And so the question here is, when the therapist reaches out her arm, can she touch the participant? And if so, where does she touch the participant? And in order to solve that question, the participant has to recreate the feeling of the 3 dimensions of the legs. So how far does the upper leg go? Where is the knee? What is the 3 dimension of that? How long is the lower leg? Where does the foot touch the floor? And so in order to restore that, to answer this question. And so the next example that I have here about the CMR is where the participant has the eyes closed, and now she has to recognize whether the sponges left and right are felt in the same position on the pelvis or legs or in a different position. And to solve this problem, the participant has to do a mental body scan to consider the 3 dimensions of the pelvis. So she will do that mental body scan starting from the back, where the therapist has her hand, and you can see that in the top left part of the picture in the mirror. And so she's doing that body scan, mental body scan from the back, and then going through the pelvis to the front, where the pelvis is then joining the upper parts of the legs in order to solve this problem. So this mental body scan helps rebuild that awareness of the 3 dimensions of the pelvis and also the relationship between the pelvis and the legs. And so because those cardboards are larger than the sponges, the position of the hands will not be sufficient to solve the task here. And then here are the MRI tasks. So we did a couple of tasks. We first took pictures of the brain at rest. Then we asked participants to imagine the sensation of the part of the body that was most painful. Then we asked them to imagine moving the limb that was most painful. Then we gently stroke the pad of the right thumb and the left thumb, and then the right big toe and the left big toe. And we did not tell them that. We just asked them to observe the sensation and then tell them if they felt something, and if so, where they felt it. And then we also did an imagined whole body movement. So first, participants would see a 24-second video of a Qigong movement, a whole body movement. And then we asked them to imagine as if they were standing up and doing that whole body movement and how that would feel in the body. And then the last task, which was with the MRI compatible robot who moved the index finger. And so the participants had to feel one shape and then a second shape and then decide whether the 2 shapes were the same or not. And so here are the pain results. So as you can see here in the graph, the red lines are the highest pain intensity level in the past week, because we ask that question every week. The orange lines are the average pain intensity levels in the last week. And we define that as the pain that was present most of the time, the pain intensity level. And then the lowest pain intensity level is depicted in green. And so the dashed lines is the observation group. So those are the participants that stayed 6 weeks at home, did not get therapy. And so in the meantime, they are receiving therapy, but we don't have the data yet. They're not complete yet. And then the full lines are the participants who started with CMR for 6 weeks and then stayed at home. And so as you can see in the highest, average, and lowest pain, there is a significant pain reduction by 2 or 3 points, and that remained low for the remaining 6 weeks. And then here you can see the sensation and the movement. So in blue are the control group. And so the control group was 6 participants and the experimental group so far 8, as the study is ongoing. And so you can see that in blue, there was no change in sensation or strength of motor function in observation when they had observation period of 6 weeks. But the other group, you can see in red, their scores before the CMR, in yellow after CMR, and then in green after the 6 weeks follow-up. And you can see a marked improvement in sensation and movement that was maintained or even slightly improved in the 6 weeks of follow-up. And so to conclude, we are very excited about those preliminary data and are using those data to obtain external funding to do the study in a bigger group of adults with spinal cord injury. And we are also organizing a class for physical therapists and occupational therapists to learn this therapy. And the first class is organized in the weekend of November 13 and 14. So if you know someone or you are a therapist interested in it, I have my email address up on the slide, so you can contact me for more information and registration. And so I would like to conclude that our outcomes can be transformative, both to understand the underlying neural mechanisms of how CMR is helping relieve the pain and improve sensation and movement, but especially also to show a potentially effective therapy that can be easily implemented and integrated as part of the existing physical therapy or occupational therapy sessions. So I'd like to conclude with a slide of the references that I used, and I thank you for your attention.
I met Andrew Taylor some years back at one of the U2FP symposiums. I can't remember which city, but Ever since I talked with him and understood a little bit of his research, I've been wanting to have him come and present to us, and I'm excited to have him here. He is an investigator in Spalding in Boston, and a PhD, and some exciting information in the exercise space, maybe some challenging information, particularly as it relates to the current standard of care. So please welcome Dr. Andrew Taylor.
Over the past 10 years or so, part of my research is focused on optimizing exercise for those with spinal cord injuries. This approach to exercise is informed by the critical importance of intensity as the key component to realize broad health benefits. For example, numerous studies have shown that higher exercise intensities relate to lower rates of high blood pressure, high cholesterol, and diabetes. In fact, more intense activity relates to both lesser risk of premature death from cancer and greater cognitive function during aging. So, more vigorous exercise equals greater overall health benefits. Interestingly, according to the American Heart Association, the biggest effect is when people move from the least fit up to the next least fit group of individuals. And this is important because just due to the effect of paralysis, those with SCI tend to be in that least fit group of people. In fact, the minimal intensity of exercise that reduces health risks can be greater than maximal exercise capacity, especially in those with a high-level spinal cord injury. Nonetheless, aerobic exercise can still have benefits, but engaging more muscle mass is critical to increasing the intensity. Now, how do we overcome this limitation in spinal cord injury? One approach is by engaging the paralyzed muscle with functional electrical stimulation. And this generally takes two forms. The first is FES alone, which in most cases is FES leg cycle. This can increase leg muscle strength and bone density. However, it does not generate a very large whole body training effect. And this is primarily due to the fact that it doesn't reflect integrated whole body exercise, but rather is just locally stimulated leg muscle activity. The other approach is to combine FES of the legs with voluntary upper body exercise. This allows for higher intensity of exercise than either FES alone or arm exercise alone. Moreover, this leads to a whole body training effect. However, one limitation of this is that the training can be limited by respiratory capacity. And this is most especially the case for those with high-level SCI. And this is what is currently driving our research. We are attempting to optimize exercise for those with high-level SCI who have the most profound limitations to exercise ventilation. Now, our work has focused on FES rowing because it has the advantage of requiring greater coordination between the arms and legs as compared with cycling. But that's not to say that hybrid FES cycling might not have similar effects and also similar limitations. Now, here's what we see with hybrid FES row training in those with a lower level spinal cord injury. This is data in individuals with a spinal cord injury below the level of T3, and this shows the relationships between injury level and VO2 peak, which is peak aerobic capacity or peak exercise capacity, and peak ventilation during exercise. It also shows the relationship between ventilation and VO2 peak. And as you can see here, prior to training, injury level directly relates to both ability to breathe during exercise and exercise capacity. And in fact, the closest relationship among these three variables is between the ability to breathe during exercise and exercise capacity. So prior to training, those individuals with a lower level of injury show a relationship between level of injury and exercise capacity, and this is at least partially due to the effects of ventilation. Now, after 6 months of exercise training with the Hybrid-FES rowing, level of injury no longer relates to exercise capacity, because in essence, we've circumvented the lesion. We provided everybody more muscle mass. However, we still see a relationship of injury level to ventilation. And in fact, the relationship between ventilation during exercise, maximal ability to ventilate, and maximal exercise capacity is somewhat stronger. And so after training with Hybrid-FES exercise, level of injury does not determine exercise capacity, but the role of ventilation remains. So as you'll see, this is even more important in those with higher level SCI. Now, here's what we see in those with a spinal cord injury above T3 before and after 6 months of Hybrid-FES row training. So this is prior to training and this is after training. And this simply shows the relationship of ventilation and breath by breath volume in response to maximal exercise and peak exercise capacity. And as you can see, prior to training, there's a close relationship between the ability to breathe and maximal exercise capacity. And in those with high-level spinal cord injury, in fact, that relationship becomes almost perfectly linear. The relationship of ventilation to the ability to exercise is much, much stronger. Hence, prior to training with Hybrid-FES exercise, ventilation partially determines aerobic capacity in those with high-level SCI. However, after training, ventilation even more strongly determines aerobic capacity. So here's basically what's going on with Hybrid-FES training in those with a high-level spinal cord injury. Before FES row training, with the untrained skeletal muscle, the lungs can easily provide the ventilation necessary to perform that exercise. However, after training, now the trained skeletal muscle in the arms and the legs exceeds ventilatory capacity. So the legs lead the lungs after training. Okay, how can we overcome exercise ventilation limitations in those with high-level spinal cord injuries with Hybrid-FES exercise? So one approach is non-invasive ventilation. And non-invasive ventilation is basically providing ventilatory support during inspiration. So helping individuals to breathe in, much like a CPAP machine. And this has been used in other populations. So for example, in obstructive respiratory problems, non-invasive ventilation during a single exercise bout increases endurance and reduces breathlessness. In restrictive respiratory diseases, exercise training with non-invasive ventilation, so regular training with non-invasive ventilation, improves endurance by more than 70%. And in a population of individuals that look something like spinal cord injury, those with inspiratory restriction due to obesity, we find that non-invasive ventilation during exercise training results in 4 times greater improvements in maximal exercise capacity. So simply by providing inspiration during exercise, we may be able to overcome the paralysis of the respiratory muscles in high-level SCI. So we have done a little bit of preliminary work with this, and I think probably our best example is simply a single case. This individual is a young, healthy male with no prior significant medical history. In June of 2014, he suffered a C5 fracture while playing in the pool. He entered our exercise training study 6 months later. And for this training study, he was randomized to arms-only training first. So he came in, he performed 6 months of arms only exercise, and then he crossed over and he did 6 months of Hybrid-FES road training. And after his participation in our research study, he then transitioned into the Spalding Exercise for Persons with Disabilities program that has as its primary form of exercise, Hybrid-FES rowing. So here's this individual at the beginning. This is his maximal exercise capacity with only the arms. So this is 6 months after injury. He comes into the study and his exercise capacity is approximately 1.2. He trains for 6 months and we see about a 10 to 12 to 15% increase in aerobic capacity. So exercise capacity increases what we see in most individuals with regular training of about 6 months. So that would be about a 10 to 15% increase in exercise capacity. So at this point, he's exercised for 6 months with the arms and he learns how to do the Hybrid-FES rowing. And approximately 1 month later, we can get a maximal exercise test with FES rowing. And as you can see, just by adding the legs, we've improved his exercise capacity by more than 40%. So a huge increase by adding muscle mass to the exercise. He then trains for 6 months. And again, we get about a 10 to 15% improvement in exercise capacity. So at this point, he transitions into the EXPD program, continuing to train with the Hybrid-FES rower. And as part of that program, he gets regular testing for aerobic capacity. And so here he is, approximately 6 months later, virtually no change despite continued training. And again, another 6 months later, further no change in aerobic capacity. At this point, we enrolled him in another study. And this was a study of non-invasive ventilation in those who had been previously training with FES rowing, just to see if we were able to increase exercise capacity just by increasing their inspiratory ability. And lo and behold, 2 days later, or 3 days later after the prior test, we see a significant improvement in exercise capacity just by augmenting his breathing. So about a 10% further increase in exercise capacity. So this strongly suggests that these individuals are training beyond their lungs' capacity to breathe, that the legs are more trained than we can actually appreciate simply because they can't breathe enough. Now, another way to overcome ventilation limitations in high-level SCI is via a drug by the name of buspirone. And this drug actually can help to augment respiratory-related activity in the brain and the spinal cord. And this is important because we know that due to lack of nervous input from the lungs and the muscles that control breathing, that respiratory-related activity in the brain and the spinal cord is reduced after an SCI, especially after a high-level SCI. And we know in animal models of spinal cord injury that this drug can reverse these impaired ventilatory responses. There's also a little bit of data in individuals that have breathing issues. We know that in both young and older individuals that have central issues with control of breathing, so in a 2-year-old after brainstem surgery and a 61-year-old after stroke, that in these individuals, there are case reports that a single moderate dose of the drug can actually correct their breathing disorders. And in longer-term treatment, we also know that loss of breathing control in those with multiple sclerosis and Rett syndrome can be reversed with chronic buspirone treatment. Now, we retrospectively assessed the potential effect of buspirone in a group of individuals who had enrolled in our Exercise for Persons with Disability program and happened to be taking the drug buspirone. So this shows data in 2 groups of individuals. One group of individuals who had been on buspirone for the 6 months of training, the first 6 months in the EXPD program. And these were all higher level injuries within about 3 years of injury. And then we matched them with individuals who are of similar age and sex and duration of injury and level of injury. and compare those who were taking buspirone while they were in the program and those who were not. And this shows two things. First of all, the improvement in overall exercise capacity was greater in those who were taking the buspirone. Moreover, only in those taking buspirone were the improvements in exercise capacity related to improved exercise ventilation. So that is, only in these individuals did we see that improved exercise capacity relates to improved exercise capacity. So this strongly suggests that we could prospectively use this drug to treat individuals during exercise training and thereby improve their training responses. So as a result of these prior findings, we're currently funded by the National Institutes of Health to attempt to improve responses to exercise training by implementing both non-invasive ventilation and buspirone. Our hypothesis is that both will improve exercise capacity, but these will act through different mechanisms. The non-invasive ventilation by mechanically augmenting inspired volumes, and the buspirone by augmenting central respiratory control. And we hypothesize that combined treatment will result in the greatest improvements. And our measurements are obviously cardiopulmonary exercise capacity. We also want to look at overall pulmonary function. And ultimately, we want to look at changes in cardiometabolic risk. The individuals that we'll be studying are those with an injury less than 2 years, all high-level injuries above T4, and every individual will be exposed to 6 months of Hybrid-FES road training, and with that will be a double-blind trial of either non-invasive ventilation or sham, and buspirone or placebo. So in this way, we're going to be able to look at the effects of 6 months of Hybrid-FES road training alone and training with drug alone, training with non-invasive ventilation alone, and the combined effect of both mechanical ventilation and drug. So from this, we hope to define whether one or both or either of these approaches to augment ventilation can lead to greater improvements in exercise capacity in those with high-level spinal cord injuries. So I want to close with thanks to all those individuals who have been involved in this research, not just the investigators, but also the volunteers, without whom we could never have done this. Moreover, we're very thankful to the various foundations and federal agencies that have seen fit to fund this research. And lastly, we want to thank Spalding Rehab Hospital for its continued support, in part through the Gordon Center for the Cure and Treatment of Paralysis.
And now we're going to hear from Ceren Yarar-Fisher, also another PT PhD. She's the Associate Professor and Director of Rehabilitation Medicine at UAB, University of Alabama. And this is another clinical innovation, particularly with regard to diet in the early stages of injury. And I think anybody who's gone through spinal cord injury and eaten hospital food might be particularly interested in the implications of her research. So let's hear from Dr. Yarar-Fisher.
Hello, everyone. My name is Ceren Yarar-Fisher. I am an associate professor at the Physical Medicine and Rehab Department in UAB School of Medicine. And today is my birthday. I'm really enjoying to record this lecture on my birthday. And I call this title A Rebel's Approach to Improve Neurorecovery, Health and Function After Spinal Cord Injury. Just think about how many $1 million has been spent on SCI neurorecovery research, specifically in pharmacological trials within the last 10 to 20 years. We have zero results in our hands. So the reason I call this talk the Rebel approach is because there has to be non-traditional ways of thinking for recovery or for improving SCI health. And I remember introducing nutrition and microbiome idea to senior investigators years ago, and they really didn't think that they were very relevant for SCI research, but I think we have started to prove them wrong. Our research focus in the lab currently is the nutrition interventions or impact of nutrition on neurorecovery, microbiome composition, and metabolic health in the acute and chronic stages of spinal cord injury. And we utilize very traditional methods of measuring neurological function, metabolic health, but we also use omics like microbiome, metabolomics, and proteomics to answer some of the questions we have in the acute and chronic stages of injury. Our ultimate goal is, in our wildest dreams, to come up with maybe a poop pill or an exogenous ketone supplement that could be utilized in the acute stages to improve neurorecovery and microbiome composition. And this could be utilized as an adjuvant therapy, which means alongside with all the impactful treatments already shown effectiveness in the early stages. And you all know that antibiotics is heavily used after injury, and we are currently also working on how microbiome is impacted from antibiotics use and how diet can maybe decrease the impact of antibiotics on the whole system. But in this presentation, we will be focusing on our new ketogenic diet trial. So we asked the question, can ketogenic diet be a potential adjuvant therapy for neurorecovery following SCI? What is ketogenic diet? And there are different definitions, and we utilize classical KD in our trials, but when you think about classical ketogenic diet, it's 60 to 90% fat. It's mostly long-chain fats with carbohydrate and protein constituting the remainder. And we don't really have time here, but I really wanted to give you a history of how ketogenic diet has been utilized in drug-resistant epileptic kids over the years. This is the only thing that works for them, and Duke University has a specific kitchen just for ketogenic diet for epileptic kids. And there is the other kind, medium chain triglycerides. Fats are provided through triglycerides, 45% of fat. It does allow a larger carbohydrate component. The benefit of that is really it's easier behaviorally to follow a higher carb content. We have not tried this in our trials. Energy is largely derived from the utilization by fat delivered in the diet, and the ketone bodies, which are beta hydroxybutyrate, acetate, and acetone, which are alternative sources to glucose. Again, this could be utilized by the central nervous system. Ketones provide alternative and cleaner source of energy. There are antioxidant effects that rescue mitochondria function, and then there are major anti-inflammatory effects. And this brought me to this, again, wonderful study. Dr. Tadslav, he's an ICORD in Canada. Now he's a good collaborator. We wrote a couple papers together, and he is really the father of ketogenic diet and neurorecovery trials, in my opinion. And one of his first papers showed that the ketogenic diet improved forelimb motor function after spinal cord injury in rodents. And specifically, the KD treatment increased the usage and range of motion, the affected forepaw, and it improved pellet retrieval with recovery of wrist and digit movements. And the spinal cords of the diet-treated animals displayed smaller lesion areas and more gray matter sparing. And if they return to a standard diet after 12 weeks, the improved forelimb function remained stable. I think, again, this was one of the first impactful studies that have done the diet intervention and then looked at the function. Okay, so after giving you a little bit of background in ketogenic diet and some of the preliminary studies, I want to tell you about our pilot trial we have done 3 to 4 years ago. This was a small trial with small funding. It was the K Award. And then we tested the safety and feasibility of a ketogenic diet intervention in the acute stages after SCI. We looked at how it affects traditional way of neurorecovery measures like ASIA measures. And we employed untargeted metabolomics to identify if there are any biomarkers associated with ketogenic diet-induced changes in neurological recovery. So regarding our study design and methods, this was a randomized repeated measure study, which means we randomly assigned people to diet or control groups. The diet group was the ketogenic diet, control group was the people who received standard eating, which means they could order anything from the hospital they want or order food from outside. We just follow what they were eating. We recruited 10 participants for this trial, but the 7 people's data were usable. There were 2 females and 5 males, about 35 years old, 4 people in the diet group, and then 3 people in the control group with acute SCI from C4 to T11 and ASIA A to D. We did neurological examinations, resting energy expenditure, blood and stool collection within 72 hours of injury or admission and before discharge. And the overall energy amount was determined according to the indirect calorimetry. So we calculated their resting energy expenditure to estimate their calorie needs for the day. And we really closely monitor how the ketosis happens within individuals in the diet. So we assumed 0.5 to 3 millimolar beta hydroxybutyrate levels in the blood as nutritional ketosis, and this was safe and acceptable. The ketogenic diet included 72% of fat, 25% of protein, and 3% of carbs during the enteral feeding, and 65% fat, 27% protein, and 8% carb during the solid feeding. And the KetoCal made by Nutricia, it's a global company who provides keto liquid feeding to epileptic kids, diabetes trials, and now the SCI trials. And this formula has 3-to-1 ratio, which is fat to carbohydrate plus protein ratio that was used in the formula. The standard diet, so we follow what they were eating. They ate 35% fat, 25% protein, and 44% carb and fiber. And none of the ST participants received any enteral feeding throughout the study. And all semi-liquid and solid food were provided by the UAB Hospital Kitchen and the Clinical Research Unit by a Nutrition Kitchen. We had 2 dietitians and 2 cooks working in the trial. Everything was super controlled in terms of feeding. Okay, regarding the characteristics and safety, I already went through the characteristics, and I want to tell you about the nutritional ketosis. So the KD group maintained nutritional ketosis over 5 weeks, the stay time in the hospital, average time. An individual beta hydroxybutyrate, fasting glucose, which are like as shown in table 1, there was a reduction in fasting glucose in the KD group, but no change was seen in the ST group. And KD group maintained a normal lipid profile in contrast to the standard diet group, which showed an increase in cholesterol, triglycerides, and low density lipoprotein at discharge. So when we actually were trying to get IRB approval for the study, the IRB board was really concerned about the lipid profiles in the acute stages. And in the pilot trial and the safety trial, we have shown that we did not really impact the lipid in a negative way with KD. In contrast, again, the ST group increased the cholesterol, triglycerides, and low density lipoprotein. Okay, this slide shows you the results from motor and sensory examinations. As you may guess, testing was performed according to the international standards for neurological classification of spinal cord injury. And the average number of hours from injury to baseline measure was about 68 hours. An AIS motor index score was used to measure motor function in the upper and lower extremities. And for the sensory examination, we tested each dermatome, both with sharp pinprick and light touch sensation, and was graded on a 3-point scale. So regarding the results, in 86% of our patients, 5 of the 7, there was no change in level of injury, neurological level of injury between the initial assessment and at discharge. And 2 patients in the KD group demonstrated improvements in the level of injury and AOS classification T10, Asia A to T11, Asia B, and C4 Asia, C2 C5 Asia D. The individual upper and lower extremity motor scores, you see it here. Also, you see the light touch and pinprick sensor scores at baseline and discharge. The KD group demonstrated an increase in the upper extremity motor score compared with baseline scores, and no change was observed in the standard diet group. Between the baseline and the discharge time points, 15 upper extremity motor score and 13 lower extremity motor score points were recovered in the KD group versus 8 upper extremity motor scores and 6 lower extremity motor score points recovered in the SD group. In addition, no effective time and group was observed in the sensory outcomes, as you see in the score. Okay, this graph is showing you our metabolomics analysis results. And when you think about metabolomics, it's the large-scale study of small molecules, and commonly known as metabolites, within cells, fluids, tissues, and organisms. And it's really an objective lens to view the complex nature of how physiology is linked to external events or disease conditions, like such as spinal cord injury. And the metabolites are really small, so some of the metabolites or some of the molecules we cannot catch with proteomics analysis can be seen by metabolomics analysis. So when you look at our results, on the left side, that's a partial least squares discriminant analysis in a fancy way, but what is really showing you is that this is the behavior of groups over time. And when you look at the purple and the red, it's actually the standard diet and the keto group starting from a really similar physiological state. But what happens over time is that they're really separating, they're behaving differently. And metabolomics informatics is telling us what is making them different. What is the ion groups that making this difference? And that we call them VIP features. They're like VIP characters. They're really important in terms of deciding on how groups behave. And when you look at these data, we saw that the fibrinogen-related peptides, alpha and beta subunits, and lyso-PC16 were the factors that are separating groups. And fibrinogen is a pleiotropic blood protein that is known to regulate neuroinflammation, was lower in the KD group, and the levels of lyso-PC16 and anti-inflammatory lysophospholipid was higher in the KD group, which is a good thing because you want inflammation to be down and anti-inflammation or anti-inflammatory factors to be up in the ketogenic diet group. Just to summarize our pilot trial, we think the most important thing to show in this trial was KD was safe and feasible. Nutritional ketosis and normal glycemia were safely achieved, and normal lipid levels were maintained, and we did not really note any adverse effects. And the neurological and metabolomic improvements I already covered in the previous slides. But definitely the greatest limitation of our study was that it was very small, and it was insufficiently powered to detect minimal but clinically important differences, as well as other potential biomarkers reflective of neurological recovery. And the primary outcome variable, which was really the neurological outcomes, could be impacted by other covariates such as injury, sex, age, rehabilitative therapies that cannot be accounted for in the present study. So we made these notes in the paper too, and we applied for a bigger grant, and we were lucky enough to get funding for doing the same study in a larger sample size from NIH, and that is the study that is currently ongoing. So this slide shows you our new study design, new protocol. It's pretty much the same as before, but we added a couple more safety measures, such as liver enzymes, and C-reactive protein. And also we added another sensory measure, electrical perception thresholds. And we're still doing our omics analysis, specifically metabolomics analysis. And this time we are shooting for enrolling 60 participants to have 54 completers. And we will again do our baseline analysis within 72 hours of injury, and then the diet will start, and we will also do 15 days of injury this time. And before discharge, instead of doing pre and post, we have a mid study measure. And normally the patients stay in the hospital from trauma to the rehab. Ending of rehab is about 5 to 6 weeks. So that will be the discharge measure. Okay, I want to show you some preliminary data from the metabolite analysis. Again, the data is being analyzed right now. We didn't have enough time to show you everything, but hopefully until maybe the meeting, Q&A session, we may have more data. But this is just looking at how metabolites change in 8 people over time in the ketogenic diet group. So as far as the results show, the creatine decreased, that indicates better renal function. Creatine, carnitine, acetyl, butyryl carnitine increased, which indicates more energy to be utilized, and glycoquinodeoxylate and biliverdin decreased, which indicates better liver function. This slide shows you the behavior of standard diet group in terms of metabolites over time. They show the opposite behavior compared to the keto group. So carnitine, propionyl, and butyryl carnitine decreased, which means less energy available to be utilized, and glycoquinodeoxylate and biliverdin increased, which indicates worse liver function. Again, these are very preliminary results. We don't have our VIP analysis to see what separates the groups, so we did not really compare 2 groups with each other. But hopefully, maybe until the talk next week or in 10 days, we may have more results to show you. This is the end of my presentation. I would like to thank all our study participants for their dedication, their time, their effort, all my laboratory, my trainees, my students, all the faculty and staff who tremendously helped in the conduct of these studies, all the funding agencies, specifically NIDLR, NIH, and Craig Nielsen Foundation, for making these studies possible, and also for their continuing support over the years. I would like to thank the centers at UAB, Microbiome and Metabolomics Center, again, for analyzing our data and providing us with informatics.
All right, welcome everybody. Just really quick, before Christel was ready to talk, just wanted to let you know we're a little over schedule, and just let you know that we're going to just let that run. So we'll go past 3 o'clock today, just because of our little technical difficulties at the front end. So Christel, please take it away.
All right, hello all, and greetings. I'm Christel Mitrovitch, proud U2FP board member, and on behalf of everyone tuning in, thank you so much for presenting your innovative and wonderful work and speaking with us today. So I'm sure there are many, many questions, so we're going to jump right in to question number 1, which will be posed to all of you. What are the challenges in procuring funding and implementing your various approaches to research? And does challenging the current status quo way of thinking regarding diet, exercise, and therapy make doing those things more challenging? Dr. Yarar-Fisher, I'll have you go first.
Sure. So I will start with the funding limitation first. That was the most impactful in my ear. But I think, yeah, everybody in this panel most probably had the difficulty receiving funding for their out-of-the-box ideas. And we were just chatting about it. I think we're so used to a certain type of questions, research questions in spinal cord injury, specifically neurorecovery, and kind of challenging the traditional way of thinking was hard for panels to understand, our ideas. For example, the ketogenic diet idea was really hard to grasp for some reviewers or some panels in NIH and other places. But I think now the spinal cord injury area is changing. We are understanding more that it's a whole body approach than just a one targeted approach. So I think the limitations and funding maybe is slightly removed. But again, the translational studies are hard to do because the translation doesn't have to be very innovative. Sometimes in funding, they really look for this innovation in the idea, but sometimes very basic ideas could be very translatable and easily doable. So, but overall, I think the funding area or status is improving for spinal cord injury. I will just stop here and
Dr. Van de Winckel?
Yes, I concur with what Dr. Yarar-Fisher said. And the challenge in the funding is that if it is a new idea, you have to present really strong preliminary data to say, okay, this is our idea, this is how we think it works, and look here, we have data that indeed it does seem to work, even if it's in a small group. And I completely agree with what Dr. Yarar said about that there tends to be a fixed mindset about this is how we did it and this is how we will always do it. And I see the trend going to a whole body approach, which makes me very excited because I feel that opens up an avenue for much more possibilities for adults with spinal cord injury.
Dr. Taylor, anything to add to that?
Yeah, I would say, even though I've been doing this for 10 years now, I'm a bit new to the field. I'm not trained in spinal cord injury, or I'm not a physiatrist or physical therapist. I'm a physiologist. And it was interesting that in getting my work first funded, I really only found receptive reviewers outside of rehabilitation. So I actually went to individuals who understand the cardiovascular impact of inactivity and how you might approach that with different forms of exercise. And they were much more receptive to my ideas than what I got from other reviewers who came out of traditional rehab areas. And so I continue to seek funding at places that are not traditionally rehabilitation oriented. So we have some work to look at bone blood flow, which may relate to osteoporosis after a spinal cord injury. And that's not funded by a rehab institute, it's funded by musculoskeletal. So, and they understand the importance of osteoporosis and how bone blood flow may relate to that. So, so I think you have to be somewhat creative and not just stay within the rehabilitation or the spinal cord injury world to find those dollars to move your work forward. In terms of translating it out, I think that we have a medical culture that's driven by reimbursement and insurance, what they will pay for. And so what things have been used are paid for. New things, I think, are difficult to get out there, especially if they take a bit more effort. So we are probably the only site using FES rowing in order to give access to whole body exercise to spinal cord injury, because it's not easy to do, and it costs some money, and nobody's reimbursing for it right now. So I think those are bigger challenges than the challenge to get funding for my research, to be honest.
Oh, that kind of leads into the next question, which will be posed to Dr. Van de Winckel and Yarar-Fisher, which is, what is your process for disseminating your research to clinicians in order to kind of change standard practice now? Dr. Van de Winckel, have you go first?
Yeah, so I actually started to set that up, and I mentioned that in my talk. We are having our first course here in the States on November 13, 14. For physical and occupational therapists. Originally, this therapy comes from Italy and is known there for decades, but the handbooks had not been translated in English. So that's why we in the States don't know so much about it. But it has been used in the clinical practice there for years. And so this is my goal. Is I already teach it as an introduction class in our DPT student class. So they are already getting introduced to this. And my plan is to bring a more thorough course line in the States so that people can implement it in their sessions.
Dr.
the-
Yarar-Fisher? Yeah.
Yeah, the acute trial is really young, so we don't really have enough data to translate into clinical practice, but we have lots of data from the chronic injuries. And then we finished a 5-year high protein and low carbohydrate diet trial. And then we targeted individuals with spinal cord injury who has insulin resistance. So we have some promising data throughout the process. We published many papers and also write nutrition fact sheets through the MSPT channel, through the Neidler model systems. And also we are preparing kind of cook recipe books for people with diabetes and insulin resistance, like easy meals that they can cook at home. These are all kind of evidence-based from our trial. So we try to educate the public through fact sheets and some online platforms through the model systems, but also Lakeshore NICPAD. We are starting a nutrition class there, hopefully soon, for people with chronic injuries. And when this acute trial completed, we will be also educating the public about what we have seen and if we have some tips for kind of adopting ketogenic diet in the acute stages. So that's our work for now.
Okay. Matthew, I just have one more question for the panel, and that is in general, especially Dr. Taylor. Kind of being, on the outside and coming into the SCI community, how are you finding your novel approaches being received in the SCI community?
I was somewhat mixed, to be honest. I think that that there's I'll be honest, I think there's a clinical concern that if we understand that sometimes exercise is insufficient to achieve certain aims, that people would think that exercise is not worth doing, and we would dissuade people from performing exercise. So I've had some pushback in terms of trying to inform my peers that, that's not something to shy away from. That's something to explore and to overcome. So we want to overcome those barriers. We don't want to ignore them because we're afraid of what they might mean for the treatment of the patient. Some of my work, I've again had to go into exercise journals versus spinal cord injury journals because of that sort of pushback. And I think that it belies a mindset that, oh gosh, we really want to help these people, and so we don't want to provide them information that may be unsettling. Versus we want to know where we're falling short and explore ways to overcome those hurdles. Versus just ignoring them.
And others, how is your work being received at this time?
And you're asking?
Sorry, Dr. Van Winckel. Go
Oh, yeah, okay.
Sorry.
Yeah, so as I said before, I believe in terms of funding, it's providing preliminary data and showing it works. And that is also what participants are interested in. It's like, okay, will it work for me? And in this particular research, it requires a change in mindset, where I hear that participants say, well, they told me in the beginning, it's not coming back. I don't even have to pay attention to it. I have to just forget the pain. And now you're asking me to focus on my legs and to focus on sensations. And so to have that switch from I don't feel anything in my legs to wait, I think I do feel something. It's different from normal sensation, but I do feel something. And that's the exciting part in the research, to see that changing mindset. And even my own mindset has changed over the course of this preliminary study, where I was told 20 years ago when I was a PT that, well, once it's complete spinal cord injury, the the recovery is scant, and I do see that happens. So of course not everyone is walking, that's not what I'm saying, but there is some recovery of sensation and movement in so far all the participants, and reduced in pain so far in all the participants. And it happens, and that responds to one of the questions in the chat, it doesn't happen at the start of the therapy. It happens for every individual the moment that they regain that sensation of the body awareness, and understanding of that, the volume and the 3V of the legs, or wherever level is injured. That's when we see the pain go down. So that's why I know it's more than just attention, because even the control group got every week a call from me or my students where we asked about how they're doing, and they could talk about their pain. So it's more than that. And it changes. For some it's in the first week, for some it's in the second week, for some it's in the third week. So it's really a direct correlation of the moment that they get aware of their legs, in this case if it's paraplegic, then it's where the pain goes down and sensation and movement improvements occur.
Yeah, fantastic.
Yeah, and just to add one more thing, because I didn't say that in the presentation, the beauty is then to hear participants at the end say how much their life has changed, and to be with markedly reduced pain, or some even pain-free, to say, wow, I have hope again. And that, to me, this is why I do this work. This is so humbling and makes me so happy.
I understand that. Matthew, it looks like you're
I guess
questions.
That's a whole bunch of questions. Let's throw one to I'm going to try to wrap a few up into one.
Yep.
So Andrew, sort of series of questions. One is, when is an FES rowing machine going to be commercially available? Alongside that, what would be the big impedance to that with FES systems? Sasha Rubchevsky asks, kind of that FES has sometimes been scoffed at, and why is that, and how do we change that? And then from John Hockenberry, it seems that both the data and hypothesis are relatively obvious and don't really add much to the general strategy that you should be more active more than inactive. But how can your discoveries lead to things that may not be so obvious, changes in practice? So all those together, do your best.
All right, I'll try to talk in bullet points. So the obviousness of it was what first struck me when I was introduced to Hybrid-FES exercise. And then when I went and looked, there was very little work, and this is about 10 years ago. And the idea of the rower is it's just sort of a holistic form of exercise. Rowing is a sport, whereas FES, arm and leg cycling is not really a sport, and it's also much more accessible. Rowers are not that expensive. In terms of having a rower made available, we currently have what's called a Science Technology Transfer Research Grant, an STTR from the NIH. And we are working with Hydro, who is a startup providing a Peloton type rower, and Myolin that produces an FES bike. And so between the three of us, our goal is to create a commercially available FES rower. Soon, we'll see. These things, what's the impediment? It's probably FDA approval is the biggest impediment. And so that's something that we're struggling with right now. We have tried to make it available to people through us. So we, connect them with the right individuals to get the stim unit and to get a rower and get the adaptations. And we can do that because we do have an exercise program that's has at its core FES rowing. So we have probably 15 to 20 people who have home rowers across the country. What did I miss?
I kind of think that's all of it. I want to add a little piece of you're basically describing a little bit of a DIY version in that last comment that you made, that you're kind of helping people figure out how to do that.
Yeah. So Vermont Waterways actually works with us to make the adaptations for the Concept 2 rower. And then Myolin is producing a stim unit that's appropriate for the FES rowing. And I think someone said the hypothesis was pretty obvious. Or no, what? Oh, FES has a bad rep. Well, right, I agree. It should. I don't think it's really not exercise. Exercise requires both feed-forward and feedback mechanisms to generate a systemic response. And just stimulating the paralyzed muscles is just local muscle activity. It's not exercise. Exercise requires central command feed-forward to increase your heart rate, to increase blood pressure. And so the FES bike alone, I term just local muscle metabolic activity.
Even with resistance?
Sure, yeah.
All right. So Ceren, a couple of questions again, I'll roll these up too. Do your participants in the study go back to a regular diet after they're out of this study, or do they stick with it, I guess is the implication from Nancy. And then I'll roll that up with Wolfram Tetzlaff's question. I know how much does a controlled diet resemble the Western diet? Which I know we talked about in our preparation. You know, like anybody who's been in a hospital for acute rehab knows what kind of diet they're getting, generally speaking. And then kind of attached to that is, can you comment on any microbiome change?
Sure, yeah. So I want to say hi to Wolf. I haven't seen him for a while. And, you know, if you watch the presentation, he's the father of the keto trial, starting from the rats or animals, animal models. But so back to your first question, and Christel kind of asked the same question. So for us, the patients really like to be in the trial when we offer them the trial and offer the potential benefits from the pilot trial results. They really jump into the trial, but maybe 20% of them within the two weeks say, this is too hard for us. We're in this catastrophic state. We want to eat brownies. We want to eat whatever we want. You know, we want to eat McDonald's. This is too limiting, and it is too limiting when you think about it. You know, they cannot really eat sweets. The carb is very well controlled. Even vegetables, they cannot eat most of them. So I think the next generation trial will be, you didn't ask this question, but I want to say it, you know, Wolf and I talked about this before, the exogenous ketones or exogenous ketogenic diet would be a better target for people with spinal cord injury in the acute stages. Some people will do ketogenic diet after the hospital, but this is really rare. Ketogenic diet is hard to do. The meals are hard to prepare, to be honest. You need to be really careful about the macronutrients and micronutrients. So I think, again, we will move into more exogenous ketone trials in the future. And Matt, what was your second question? I'm sorry.
I guess it was the first one, which was, do people stick with it?
No, I mean, some of them do, some of them don't. Again, I don't know the numbers, you know, we don't have the follow-up in the trial if they continue their diets, but I think Wolf's question, now I remember, was the chronic or the standard diet or the control diet in the hospital.
Yeah.
So, so it really looks like the Western diet. And again, in the control diet, we don't feed them. We follow closely what they eat. We weigh the food left in their tray. Even they order McDonald's or something else from outside, we have the calorie calculations and everything. We weigh the food. We know how many calories they get and what the proportion of or macronutrients they received. It looks like high fat, high carb, very low protein diet, which is a Western diet with really low fiber intake. So yeah, the control diet becomes the Western diet in the trial. And I think that was all the questions.
I think so.
Anything else, Matthew?
Well, I guess, yeah, not from the chat board.
Okay.
Go ahead and kind of, we have just a few minutes left.
I can address some of the questions that I had in the chat board if you want. I wrote them down.
Oh, did we not get to them, Ann? My apologies.
No. So one question was if improvements are possible multiple years post-injury, and the answer is yes. Our participants were between 1 and 56 years after their spinal cord injury. So the answer is yes to that. The other question was, why did you not enroll children and teenagers? That has to do with the brain imaging that we do. So this therapy definitely also works for children. It's being used in Italy for children as well. But when we look at the brain, we like to split those studies because the children have a developing brain. And so it has a different function, or it functions a little bit differently than a person who is an adult. So that is why in this study, I don't have children, but that doesn't mean that in the future that cannot happen. And then there was a question about plans to have trials in more locations. So yes, and that is also part why I set up classes so that more therapists abroad and across can learn about this, so that in the future we can collaborate with multiple centers and do a bigger study. And I think that those are the questions for me.
And one thing I just forgot, I saw on the chat box, I think Wolf asked also about the microbiome. We just received the results this week, and the alpha diversity and beta diversity is pretty much, alpha diversity shows you how this sample behaved within the time frame. So it's kind of looking at within sample, and then beta diversity is looking at two different communities, like diet group and the control group. So the alpha and beta diversity were significantly different between groups. And we look at PQA graphs and we kind of color them. And we saw that, again, two groups behave differently, but we couldn't do any taxonomy. I didn't have time to bring results to here, but it seems like two groups behave differently. Is it, whether it's positive or negative, we don't know yet. But hopefully within the next couple of weeks, we will have those results from the first 10 people.
So very simply, what you're saying is there are changes, you just don't know what they are just yet.
Yeah, we don't know if they're a benefit in the keto group or beneficial, but definitely the behavior is different.
Okay.
Interesting. All right, kind of wrap up. You've all talked about your areas of research and how it's contributing to this whole body approach. And seeing as that is the case, do you consider these potential innovations, do you see them being applied in future practices for SCI community? And then with that, are there any changes we can make right now in standard practice? Dr. Yarar-Fisher, I'll have you answer.
Yes, the immediate suggestion I could give you, the data is rich in there. Do not feed acute individuals or with injury in the hospital with lots of sugar or glucose. So one thing we realized over a couple of years, that even the medication is mixed in dextrose solutions, and nobody knows why in the acute practice. You know, when you ask a doctor, they don't know, and a pharmacologist send these solutions and they don't know why. It's just a common practice in the hospital to mix them in the dextrose solution. So we can tell you that a lot of glucose in the acute stages kills neurons, and there are poor outcomes with high glucose levels, even in the human trials. So no glucose is better in the acute stages.
Okay. Dr. Taylor?
Intensity. The harder you work, the better the benefit. And I think if we just adhere to that principle when we prescribe exercise, I think we'll see huge benefits.
Fantastic. And Dr. Van de Winckel?
So the answer is yes. And even to implement, even if you wouldn't be like familiar with the exercises, the goal in our study is that people go away and apply this in daily life. So even if from the beginning, being aware of the contact with the soles of the feet, even if there is complete loss, just focus on it during the transfers. Like take just 1 second back before doing the transfer to be mindful of that shift. Also, when you shift the pelvis to transfer, that there is more weight on the feet, and to be aware of where the body is to involve the arms and tell your brain, like, these are the legs and they're still part of your body. Those are things that everyone can implement right away.
Wonderful. All right.
Well,
Matthew, I'm good.
Yeah, thank you. Appreciate your research. Appreciate your time with us. Thanks so much.
Thank you.
Thank you all.
And
Very
for
helpful.
you out there, give us a minute. We'll be right back. All right, we're back, everybody. Thanks to Anne and Andrew and Ceren and Christel. I think that was a really interesting session. Now I want to introduce you to Cynthia Templeton and Tommy Suter. And in particular, want to spin this conversation off a little bit into the activity-based therapy, activity-based exercise space in particular. And just a really quick background, Cynthia and Tommy have been part of a group that's been meeting for a while towards this idea of kind of helping to corral all the activity-based therapy and exercise centers, community-based all over the country, looking to kind of harness what is maybe been unharnessed for some time. And also as it relates to the kind of practices that are being done at those spaces, also sort of represent a kind of challenge to some of the status quo in rehabilitation medicine. And so we want to have a conversation about that. So welcome, Cynthia. Welcome, Tommy.
Thank you.
Thanks for having me.
Yeah. Yeah. So give us a little background on the two of you real quick.
Okay, I'll start. I'm the Cynthia Templeton. I'm the founder of Push to Walk, which is located in New Jersey. My son sustained a spinal cord injury in 2004. We opened our doors in 2007 and are growing all the time as a specialized ABT gym, specializing in neuro exercise, and knew that over these past 15 years that Push to Walk has been open, that we needed to organize ourselves into some kind of formal organization, and so have taken on the task along with a few other members of the community, not with us today, but as Tommy is talking, I'll share a document that has the information about our other founding members of the association.
So Tommy, tell us, yeah, you come out of Push to Walk, of course. But where are you now?
So I'm kind of a continuation of what Cynthia just said. I got a job as a trainer at Push to Walk back in 2011 and was a trainer there for a few years, was the program director, and then eventually left to pursue a rehabilitation science PhD from the University of Florida. And after that, I did a short postdoctoral fellowship at the VA hospital, the Malcolm Randall VA in Gainesville. And then from there, I actually transferred up to the Hunter Holmes McGuire VA hospital in Richmond, Virginia, where I'm currently continuing as a postdoc.
Cool. So let's talk about this association a little bit more.
Okay, well, I have up on the screen the other founding members. It lists their names and contact information. I can always try to figure out how to share this with you after the conference. But I just wanted to mention that the ongoing support of Alfredo and Tricia, along with Matthew and me and Tommy, has been what's moving this group forward. So I'll just take that off the screen. So the mission, well, Tommy's going to talk a little bit about the tie-in to the research, and then I'll go into the mission of the association.
Yeah, so sort of tying into a lot of the things that we heard in the previous presentations, although I will admit that some of the things that in the previous presentations are actually novel to what goes on compared to what goes on in some of the community activity-based gyms in the country. And that's one of the reasons why we felt a need for this association, is that there are lots of great things going on in the research or the medical world. And there's lots of great things going on at these centers, but the knowledge is not necessarily standardized from center to center, and there's never been a central or standardized way to get information not only from center to center, but also between these community-based centers that aren't always necessarily tied to the medical and research world, to transfer the knowledge from these centers to research laboratories or other players in the medical and translational world. So we believe that one of the one of the gaps that this association can fill is in delivering the best and most appropriate opportunities, not only to just improve health and fitness, but working towards the ultimate goal of improving neurological function and the potential of anybody living with a spinal cord injury or other neurological disorders. And so I guess, Cynthia, that segues into the mission.
Right. So the mission itself of the association is dedicated to support the professionals and the organizations that deliver these exercise-based programs to people with neurological conditions resulting in paralysis. And to that extent, what we want to do is to provide support through education and mentorship and sharing best practices, sort of in the broad context of both administrative operations and program operations. We also want to help people form new centers. From our latest calculations, there's between 50 and 60 exercise centers around the country now, which is a huge growth. I know since Push to Walk opened in 2007, but there still needs to be more. The more access that people have to centers like the ones that already exist, the better off people will be to have programs sort of in their backyard, in their communities, so that they don't have to travel, and relocate for a certain amount of time to avail themselves of those services. So to help people and groups form new centers.
Can I interject?
Sure.
One thing that I think about is, in a sense, what you're both saying is more, like we need more centers, we need more connection, we need more best practice, right? We need to elevate business practice, we need to elevate clinical practice. We need to elevate just the number of places and the number of connectivity. And I think of all of this as capacity, right? So I know U2FP's interest in this is the recognition that both for quality of life and the continuation of quality of life, meaning curative interventions, there isn't enough capacity right now to maximize both quality of life now and quality of life in the future. And so our interest is to really help more, right, in this. And then the other piece is, which I think you're probably going to mention, is, maybe talk a little bit about the partnership with the U of M that we initiated to do a public health impact study on the effect of exercise and how this kind of weaves into that more strategy.
Yeah, so we definitely need more of everything. And part of that is sharing information and being open and transparent with what we do to help others open places, because one of the big drawbacks is that most of the centers, like Push to Walk and others around the country, is private pay and out of pocket. And how do we have these public impact studies done to show the effectiveness of the programs and why the medical community, and insurance companies particularly should be interested in what we're doing? So Tommy will speak about the public health study.
Yeah, so I think, again, going along with that more theme, I personally have always found it, I've always wondered why there isn't more engagement between these activity-based, these community-based centers and the research world in particular. And I'm not saying that it doesn't happen. It's certainly there have been partnerships that have yielded useful information. But again, I think I do believe there needs to be more of it. And I think it would be to the benefit of both the research world as well as this community-based, activity-based training gym world. And so this association that we're forming as a first foray into trying to get more of those kinds of relationships going on to get more information that's useful to the spinal cord injury community as a whole, is this public health impact study that our partners led by Leslie Morse at the University of Minnesota, we've begun to undertake. And what we are doing is sort of as an initial step, we're just kind of collecting baseline information, not only about each center, so like how long it's been around, what the location is, does the staff comprise of exercise physiologists, physical therapists, a mix, other types of professionals, but also just information about the people that utilize these centers. You know, what is their baseline health like? What kinds of, you know, mobility devices do they use? How far away do they live from what might be considered a local gym? How many people are training on a regular basis and therefore might have a more regular impact on their lives versus people who have to travel a long way and only can do, like, you know, a 3 or 4 week intensive boot camp, so to speak, and then have to continue as they get home. And you know, the process of collecting this data and looking at it has been ongoing, but behind the scenes, we've already found some interesting information about how a lot of people who utilize these centers almost paint a different picture of the spinal cord injury community when compared to a massive data set such as like that which we might get from the spinal cord injury model systems. And so we think that this could be an opportunity to really comprehensively understand not only what are the impacts of these centers, but perhaps give us a more comprehensive picture of the spinal cord injury community as a whole, what the spinal cord injury community needs from the research community, from the medical community. And then again, thinking many steps down the line, thinking forward, you know, this will hopefully be the first of many engagements between these local community centers that are delivering all kinds of interventions directly to the people with people who are further behind in the translational spectrum, like in clinical research labs, like myself, or even basic research labs. So we're pretty excited about the potential of what we've done so far. And hopefully we're gonna have some information to share, if I'm estimating safely, probably by next year. But there will be, for anybody who's interested, and I think this might be a good time to switch back to Cynthia to talk about kind of the call to action that we're hoping for. For anybody who's interested, we'll be providing updates, you know, as we have them on both the development of the association and this first public health impact study that we've initiated.
And before we go to Cynthia, let me just ask you one quick question, because I think it might be on the minds of some folks, particularly in the audience with an SCI. Like, well, why do you need to have a study that exercise is good for public health impact? Like, and maybe more specifically, hasn't that been researched in the past? So explain why that's important.
Do we have another few hours?
No, I'm actually looking for, I kind of know the answer, but I'm looking for the simple question of, you know, what Leslie recognized is that there's been lots of studies, but
there have been lots of studies on things like, you know, how might FES or cycle ergometry improve cardiovascular health, or there have been lots of studies on, you know, how does this stimulation intervention affect nerve function, which may ultimately affect movement. But what we've heard anecdotally, I mean, for the last 20 plus years from a lot of people who utilize these centers is that the benefit that they get from doing this type of intensive exercise, you know, as often as they want, or at least as often as they can pay for, isn't necessarily quantified by sort of the classical, you know, neurological or cardiovascular outcome measures that you might get in sort of a standard laboratory test. So a lot of people, you know, they'll tell you they have more endurance, they can get through their day better, they're more confident when they drive or when they're transferring or things like that. And you know, in us in the research community, you know, we have to believe what these people are saying. You know, if they say they're getting a benefit, we can't just dismiss it as the placebo effect. But the disconnect is that a lot of the outcomes that are used in these studies, I'm not saying that they're not important, because they absolutely are, but they don't capture, you know, all of the aspects of life that are important for people in the SCI community. And so this public health impact study, again, it's not going to answer all of those questions, but it's a first step to not only establishing the relationships needed to do more studies like that, but also, you know, just trying to get a general sense of an idea of, you know, okay, what are people saying are the benefits out of utilizing these centers, and how do we actually start quantifying, yes, this is definitely happening versus maybe this is more subjective, again, with the ultimate goal of giving more people access to these services and also making it more affordable for people.
Yeah, so I think in summary, a couple things. One is to be able to do that in a large number of people.
Absolutely.
There's been a lot of small pilot studies sort of examining all these little nuanced questions. And then the other is, in that big data set, can there be the idea of public health impact would it be cheaper to pay for exercise in a community-based center than it would be to deal with a pressure sore for 6 months, right?
Exactly.
That's the key question, and proving that rigorously in a large group of people with scientific data, right?
And I think, you know, one of the limitations of spinal cord injury research that a lot of people point out is it's hard to get, you know, the numbers. It's hard to get large sample sizes to really paint a comprehensive picture. But I believe we already have data from a simple survey that we've been doing the past year. I want to say it's close to 200 people from East Coast to West Coast, North and South, and more people are participating and sending in their data fairly frequently. So we have the potential to utilize all of these centers where you have lots of people with spinal cord injury that come sometimes week after week, year after year. They're consistently there putting in the work for themselves. But we think this could be a great resource for the research and the medical community to expand those numbers and get more comprehensive and solid data to answer these questions.
Great. Okay, Cynthia, we got about a minute, maybe half a minute. So wrap it up.
Oh man, that's not fair. So just because research is just one part of why we feel the association is important, but in this forum, of course, we're dealing with the scientists and the researchers, and it really ties in perfectly to the researchers having the ideas and the knowledge, and the centers having the client population, the people that they need to conduct these studies. But in addition to that, we really need more centers to join our effort. So if people can please email, I have in the chat box our Gmail account, and we're just looking for more centers to sign up. We're looking for the people who are either on the program side or the administrative side to share their knowledge. Knowledge, the old saying, knowledge is power. We would offer networking opportunities, education opportunities. We might be able to put together some purchasing power as a group to decrease our costs and increase the effectiveness of our programs. And we really want a lot of different people to participate. All of your voices matter. Whether you're an executive director, an operations manager, a trainer, and there's really no reason not to sign up. We're not asking for any money. We're not asking for a lot of time. If you do have an area of expertise that you want to share with us as one of our committees, we are all ears. We are willing to accept help in any number of areas that you can imagine any business like an association needs. So please reach out. We'd like to grow our numbers, grow that capacity. And as Matt says, do more.
All right. Thanks, Cynthia. Thanks, Tommy. So you heard it. The association, the folks are looking for more partners, more heads, more ideas, and that includes everyone. So if you're a person with a spinal cord injury, utilize a center, go to that center and let them know. If you're representing a center here in the audience, please get in touch with these folks. If you're a scientist and clinician looking to connect, maybe Andrew Taylor's going to roll out some FES rowing machines in some centers.
We're here to help.
Any and all of the above. So thanks you two for being here. I really appreciate it. And check the chat board where Cynthia put up the Gmail. And also one quick thing, Anita put up on there a connection about a similar effort in Canada. And I know there's been a little bit of conversation. I think there's an opportunity there to work together as well.
Perfect. Thank you, Matthew. It's an honor to be here.
Thanks.
To have you.
Bye, everybody.
Okay, so now we're going to move on to the next session, which is a focus, as I mentioned earlier in my remarks, on sexual function. So we've got 3 presentations from Lieke Kulin, Barry Komisarek, and Mark Lee Alexander coming up, all of whom have been doing this research for quite some time. I think you'll find it interesting, provocative, and then we'll circle back with them to have a conversation about it then. Okay, and remember, we're also, as I said, we're running a little bit behind, so planned on your calendar. We're going to go over time, hopefully not too much. We'll try to rein it in as the day goes on. Okay, here we go. Now I'd like to introduce Lieke Kulin, PhD and Associate Dean of College in Kent State University. She will be presenting on her long-standing research in preclinical studies on sexual function, particularly in male rats. But she has uncovered some exciting things over the years and has the potential for translation. So please welcome Dr. Lieke Kulin.
Hello, my name is Lieke Kulin. I'm a professor in biological sciences at Kent State University, and I'll talk to you today about towards recovery of sexual function after chronic spinal cord injury, focused on preclinical studies that we've been conducting in my laboratory in male rats. The sexual dysfunction that we focus on in my laboratory is ejaculatory dysfunction, as the majority of men with spinal cord injuries suffer this specific dysfunction. And you all know that regaining sexual function is a priority for men with spinal cord injury. Ejaculation is controlled by a reflex generator that is located in the lumbar sacral spinal cord and is referred to as the spinal ejaculation generator. However, its exact location in the spinal cord was unknown prior to 2002. The spinal ejaculation generator integrates sensory inputs during sexual activity with an autonomic and motor output that needs to be coordinated in order of ejaculation to occur. Even though this reflex is controlled at the level of the spinal cord, this generator is influenced by supraspinal inputs, including primarily tonic inhibitory inputs from the brainstem, although there may also be some excitatory inputs during sexual activity. This is not completely understood. What is also not completely understood is which neural pathways mediate the ejaculation-related pleasure, or what we call in humans orgasm. So my lab decided to focus and discover the location and the function of the spinal ejaculation generator by using a preclinical model, the male rat. So we first did studies basic discovery studies to identify the spinal ejaculation generator, to then study its function in an uninjured animal, to then study its dysfunction in a spinal cord injured animal, hopefully to lead to new treatment options for dysfunction in a spinal cord injured state. And indeed, we discovered the exact location of the spinal ejaculation generator in male rats and discovered that critical neurons that that are part of this generator are a population of neurons that we refer to as lumbar spinothalamic cells. These cells are located right around the central canal in laminae 10 and medial lamina 7 in lumbar levels, spinal levels 3 and 4. And they're referred to as lumbar spinothalamic because in addition to the location in the spinal cord, they also have projections up to the thalamus that we hypothesize are important for orgasm. But what we're focusing on for the topic of the talk today is how they function within the spinal cord as being the spinal ejaculation generator. They process sensory inputs and project to autonomic and motor neurons. But what's important as well is that they express 4 different neuropeptides: galanin, gas-releasing peptide, and enkephalin, and cholecystokinin. And they're triggering ejaculation by releasing these 4 neuropeptides. And they release these 4 neuropeptides onto these preganglionic sympathetic and parasympathetic neurons, as well as motor neurons that together trigger ejaculation. And here you can see some photos of their location within the spinal cord. And here you see spinal cord of a male rat, and you see this column of neurons comprising the spinal ejaculation generator, here visualized by one of the neuropeptides, galanin. A few years ago, it was shown that in humans, the spinal ejaculation generator is comprised of these exact same neurons at the same spinal levels, L3, L5, and they also express the same neuropeptides here shown as galanin. They even have the same shape of the neurons in male rats and humans. So that is really important because it means that our findings in male rats may indeed translate to its function in the human. So for many years, we've tried to address many different questions regarding the function of the spinal ejaculation in male rats. The one that is most important to focus on for the talk today is how these neuropeptides in the LST cells are indeed critical for triggering ejaculation. And so we're hoping that this basic discovery, which turned out to be the same in humans, and studying the spinal ejaculation generator in rats can then translate to its function in human health. But of course, important for today's talk, to then find out what has been changed in the spinal ejaculation generator and its function as a result of spinal cord injury. And for this, again, we use the male rat model to make these discoveries. The spinal cord injury model that we use in our animal and our rats is a contusion injury, which consists of a brief spinal cord compression. I'm sure you are all very familiar with this injury model in our animals. The injury occurs at mid-thoracic levels, so T6, 7. These animals are then, of course, treated with analgesic antibiotics, and we give enrichment in their cages. And about 4 to 6 weeks later, we record physiological parameters of ejaculatory function. These parameters closely parallel those in human males, and we also test effects of treatments on those ejaculatory parameters or ejaculatory function. To stimulate ejaculation in these animals, we use dorsal penile nerve stimulation. Our animals are fully anesthetized. We then stimulate the dorsal penile nerve. This triggers ejaculation in these animals, and we can record parameters of both the emission and the expulsion phase. And you see that here below. So we record pressure changes in seminal vesicles, which is a parameter of the emission phase, the secretion and movement of fluids. And we record from a muscle called the bulbar cavernosus muscle, EMG recordings, which is a parameter of the expulsion phase of the motor outflow. And those closely parallels those seen in humans, and you can see a trace here of bulbar cavernosus muscle bursting during an orgasm, and you can see how similar this looks of the bursting patterns in our male rats. This bursting is also not seen during any other function, such as micturition or other parameters of sexual function. However, for this to occur in a control animal, we need to perform an acute spinal transection to remove all tonic inhibition on the spinal ejaculation generator. And keep this in mind because this will come back in 2 next slides. So we first had to show that the spinal cord injury, this contusion injury in rats, indeed caused ejaculatory dysfunction similar to that seen in men with spinal cord injury. And indeed, we were able to show this. Contusion injury causes a very severe disruption of the ejaculatory reflex. In this experiment, animals first underwent a contusion injury at this T6-7 level, or a sham control. 6 weeks later, we recorded parameters of ejaculatory function, bulbocavernosus muscle bursting, and these pressure changes in the seminal vesicles. And here you see some traces of a sham control animal. And we did this by stimulating this dorsal penile nerve. First, at parameters that reliably trigger ejaculation in control animals, as you can see here. But with those control parameters, we saw no bursting of bulbocavernosus muscle and no changes in seminal vesical pressure in our spinal cord injured animals. Evidence of an ejaculation. We then also stimulated the dorsal penile nerve with higher stimulation parameters that we would normally not use, and still we were unable to elicit any bursting in our spinal cord injured animals. Hence, spinal cord injury caused an ejaculation. What is also important in this experiment, we still performed a complete isolation of the spinal ejaculation generator from all supraspinal inputs by this acute spinal transection right at the time of testing. This is important to realize for this experiment because this anejaculation that we see in our spinal cord injured animals is therefore not a result in any changes or differences between sham and spinal cord injured animals in any remaining supraspinal inputs, but rather anejaculation is due to this thoracic spinal cord injury induced changes in the spinal ejaculation generator itself, even though it is located in the lumbar sacral spinal cord. So that led us to hypothesize that perhaps spinal cord injury reduces these neuropeptides that are located within the spinal ejaculation generator, specifically within these LST cells. And indeed, we were able to show that, and these were experiments done by two trainees in the lab, Walker Wiggins, an MD PhD student, and Sid Geikwet, a then PhD student. And what they showed is indeed there were changes in both messenger RNA gene expression for the neuropeptides galanin and gastrin-releasing peptides. So here you see the levels in sham. Here you see the levels in spinal cord injury, significant reductions, as well as the peptide expression for these neuropeptides. Here you see galanin expression, here you see GRP, and especially gastrin-releasing peptide was very severely impacted. You can see that the galanin expression is still somewhat there, and so we can still see the cells. So the good news is the spinal ejaculation generator cells are still intact, but it's the neuropeptide expression in those cells that is severely impacted. And when this neuropeptide expression is impacted, that means that there is neuropeptide release reduction from the axon terminals, and that can lead to ejaculatory dysfunction. So we decided to test whether a neuropeptide receptor agonist treatment can therefore overcome this dysfunction and recover ejaculatory function in spinal cord injured animals. And so this is an experiment again. Animals underwent a contusion injury at T6-7 levels or a sham control. 5 to 6 weeks later, they received a pharmacological experiment. First, a control trial with just infusing saline intrathecally at the level of the spinal ejaculation generator. And we then stimulate the dorsal penile nerve to see if we can stimulate ejaculatory reflexes. Next, the same animals then underwent an agonist trial for a GRP receptor agonist or mu-opioid receptor agonist, galanin, for all of these different neuropeptides, and again followed by a dorsal penile nerve stimulation. In this experiment, though, in contrast to the experiments that I showed you before, we did not isolate the spinal ejaculation generator from all supraspinal inputs in an effort to make this a little bit more translational to a human situation. And what we found was very promising. So here's we're going to show you some results of gastrin-releasing peptide infusions. And as you can see right here, we were indeed able to trigger ejaculatory reflexes, bulbocavernosus muscle bursting in spinal cord injured animals. In fact, we saw an effect that was greater in spinal cord injured animals than in sham animals. And here you see the traces from our spinal cord injured animals beautiful bursting pattern of the bulbocavernosus muscle. We were not able to trigger changes, though, in the seminal vesical pressure, and so therefore the emission phase was not triggered by the infusion of DRP. However, when we next in those animals stimulated the dorsal penile nerve, we see a much more robust ejaculatory reflex. So again, infusion of GRP, but now followed by a dorsal penile nerve stimulation, you can see that almost all of the spinal cord injured animals responded with an ejaculatory reflex. 90% of the spinal cord injured animals responded, and we had a greater effect in the injured animals than in the sham animals. And again, here you see the traces, beautiful bursting patterns, very indicative of ejaculatory reflex. In addition, in half the animals, we saw emission parameters triggered as well. I'll show you one more experiment where we now infused a mu opioid receptor agonist to mimic the effects of enkephalin, one of the other neuropeptides. And again, here we see the effect of mu opioid receptor agonist. In addition, DPN stimulation, beautiful bursting reflex in those animals. 100% of the spinal cord injured animals responded to this treatment. And we also saw changes in the seminal vesical pressure in those animals. So these are really promising and interesting results where we're able to overcome the ejaculatory dysfunction in these animals by intrathecally infusing a neuropeptide agonist for the allosteric neuropeptides. So the take-home messages for the talk today is that the spinal ejaculation generator is still functional after chronic SCI, but neuropeptide synthesis and thereby release appears to be disrupted. Neuropeptide receptor agonist infusions intrathecally were able to partially restore ejaculatory function. However, I really want to caution, even though this is really exciting, I also want to be cautious in my take-home messages here to say that treatment development is still very far in the future. First of all, specific agonists for gastrin-releasing peptide, some of these opioid receptors and ghrelin receptors are not currently available. In addition, it's very likely that local delivery onto the spinal ejaculation generator may be required for recovery of dysfunction. There are problems with peptide agonists for penetration of the blood-brain barrier, but also receptors for these neuropeptides are expressed throughout the central nervous system. And so a systemic injection of an agonist may not be advantageous because actions on receptors in other parts of the central nervous system may actually cause inhibition of sexual function. So with that, I would like to thank all the people that were involved in these studies, both the earlier studies as well as the current studies. And I also would like to thank all my funding sources, specifically the Greg H. Nielsen Foundation that has been funding all the research that I showed you today, as well as funding by the Department of Defense and the Brain Health Research Institute at Kent State University and the NIH for some of the earlier studies. Thank you so much for your attention, and thank you for listening.
And now welcome Barry Komisarek, has a PhD and is the Distinguished Professor of Psychology at Rutgers University in New Jersey. Barry's been around this space a long time, as you'll see from his presentations. Some of the publications and information goes back quite a while. Done some groundbreaking work, but is still at it, and is maybe even looking for some new studies, new collaborators, and folks from the SCI community who might be interested. So please welcome Dr. Barry Komisarek.
Hello, everybody. First, I'd like to thank Matt Roderick for a kind invitation to present my findings at the Unite to Fight Paralysis conference. I'm going to speak on the evidence of response to vaginal cervical self-stimulation in women with complete spinal cord injury at or above T10. First, I'd like to give you an idea of how I got into this area. It's been known for many years that there is a connection between the nervous system and the endocrine system. And more recently, that the link is between the brain and the pituitary gland, hypothalamus and the pituitary. And a mechanism that was studied is that sterile mating in rats produces the hormones of pregnancy, but the rat isn't pregnant. And she can show a development of the placentas, but she's not pregnant. And that was shown to be a result of the mating stimulus. And in subsequent studies, artificial vaginal stimulation with a glass rod was shown to produce the same effects. And so we were studying that in terms of recording brain activity in the rats of single neurons, and in response to the vaginal stimulation and the modulation by hormones and how they affected the hormone secretion. And in my own laboratory, I made an interesting and surprising observation that when I applied the vaginal cervical, when I probed against the cervix through the vagina, it produced an immobilization in the rats. This short video will demonstrate that. Normally, the rats show a good leg withdrawal to foot pinch response. And then when I applied very mild probing against the cervix, like that, without even holding the rat, notice the immobilization. And when challenged with a foot pinch, there's no response. They don't respond, they don't show the leg withdrawal, and they don't vocalize. So I started studying this as a possible pain blocking mechanism. This is a standard test where I put the tail under a hot light, and you see it takes about 2 seconds for them to normally flick their tail away. We would do the same with the finger. And during the probing of the cervix, there's no response at all. And it can go indefinitely. We stop before it produces any tissue damage. So it's a very dramatic effect. But the question was, does it really block pain? I did a number of neurophysiological studies in the rats to test it, and it seemed like it, but I figured that the best scientific answer would be to ask women. So in collaboration with Beverly Whipple, who did her doctoral dissertation on this with me, I designed a hand holder for the stimulator. I made it out of a modified tampon with a soft cotton tip, and that's for the vaginal stimulator. Put it into the handle, and the women would twist the handle. It's not a vibrator; it's just a passive stimulator. But they twist the handle forward, and it puts pressure on the anterior wall of the vagina. And for the cervix, had them fitted by the gynecologist with a diaphragm, put a Velcro disc, matching discs, and then so they pressed against the cervix, and the Velcro kept it centered, and the diaphragm protected the cervix. So they back and forth, they stimulated the cervix. So that's how I got the vaginal and cervical self-stimulation. And to test the pain threshold, they put the finger on this called a plinth, about 1 millimeter in diameter, and this presses down on the finger. And this is the device that it has a motor that moves a weight out along the arm, and it puts more and more force on the finger until we say stop when it, tell us when it hurts. And we lift up the arm and do the next finger. So we get the pain threshold that way, the point at which the force first feels painful. When we measured that in 10 women, we found that when they applied in the control conditions, there was no significant effect. But when they applied pressure to the anterior wall of the vagina for 1 minute and 5 minutes, they continue for 5 minutes. We got about a 50% increase in pain threshold that habituated after 5 minutes. But if they did it in a way that felt pleasurable, then the thresholds built, and up to about 80% increase. And if some of the women continued to orgasm, and the thresholds went up over 100%. In other words, they needed 100% more force on the finger before they said it hurt, while they were having an orgasm. And we also measured their touch thresholds at the same time, and those didn't change at all. So that means that the vaginal stimulation is producing analgesia, specific pain blockage, as opposed to anesthesia. So then the question was, what are the sensory nerves that carry the sensation? In rats, I cut these three nerves, three pairs of nerves that carry the sensation. This is in women. The pudendal nerve carries sensation from the clitoris, the pelvic nerve from the vagina and the cervix, and the hypogastric nerve from the cervix and the uterus. If I cut these selectively in rats, the only effective nerve that when cut blocked the analgesic effect was the pelvic nerve. Almost completely eliminated the analgesic effect of the stimulation. But what about in women? So in women, here I collaborated with Mark Osipsky, who was now Alexander, and also on our Symposium. And she did the testing of the characterization of the women with the spinal cord injuries. And so the pelvic and pudendal nerves enter the spinal cord at the S2, 3, 4 levels. Whereas the hypogastric nerve enters the spinal cord at the 10, 11, and 12 spinal cord levels. Those are the vertebral levels are about L1, 2 into the conus medullaris. That's the sacral spinal cord. And so the experiment was to study women who had complete spinal cord injury below T10 that would block the pelvic and pudendal nerve access to the brain, and but allow the hypogastric access. And by contrast, a higher group of women who had the complete spinal cord injury above T10 that would block all the nerves. And my assumption was that this is going to block all the completely block the effect of the vaginal cervical stimulation. But to my surprise, that group actually had the highest analgesic response. And this was, how could this be? If all the genital sensory nerve pathways to the brain are cut, how could they respond? I said the only possible way is that there is a pathway that goes outside the spinal cord, and that the only possibility would be the vagus nerve. So now, furthermore, in those women, in those 5 women with a complete spinal cord injury at the high level, they all said that they have menstrual cramps normally. They have no other sensation below the level of the injury, no movement, no sensation, except of all things, the menstrual cramps persist. And they all could feel the vaginal or the cervical stimulation. 3 of the 5 women had orgasms from the stimulation, which was the first time since their injury, because their doctors told them their sex life is over. And they all had the analgesia above the level in that group to the vaginal or cervical self-stimulation. So I hypothesize that it's the vagus nerve, because that's the only possible other nerve that goes outside, but it doesn't go to the pelvic region in the classic view. This is the classic view of how the pain gets from the finger to the brain, entering via the radial nerve at the cervical level. And then during the vaginal or cervical self-stimulation, stimulating these nerves activates the descending norepinephrine and serotonin pathway in the lower brainstem, and that blocks the input. We demonstrated that in rats. And so my hypothesis is that when the genital spinal pathways are blocked by the injury, then the alternative is that the vagus nerve must activate the descending pathway to block the input from the finger. So the vagus nerve projects to its projection to the brain is in the medulla, in the region called the solitary nucleus, actually the nucleus of the solitary tract. And so the only way to know that is by doing functional MRI. And that's how I got into measuring functional MRI to see if this region of the brain was activated in these women when they applied the vaginal cervical self-stimulation. And I found that in every case, we got activation of the solitary nucleus in all those 5 women. So that supports the idea that the vagus nerve is the critical nerve. I've subsequently was interested in where the genital stimulation projects in the brain, and the classical view is that it goes to the postcentral gyrus. That's the somatosensory cortex. Penfield mapped the sensory cortex and what he called the homunculus, showing that in awake humans waiting for, he was preparing to do epileptic neurosurgery on them, and he stimulated different parts of the sensory cortex and showed that about half of the region, the people said that they feel like their face or their hand is being stimulated when he did the electrical stimulation in this region. And he mapped the leg, the whole body, and the leg. Here, the foot is in the medial region, and when he stimulated down deep in this region, medial region of the cortex, they said that he could feel their genitals. He did it almost exclusively in men. That region is called the paracentral lobule. This is where it is in a front view, a top view, and a side view. And so what we did in men was to see if we get the same, if we could replicate its effects with the functional MRI. We got exactly where the same region of the paracentral lobule here is where we got the activation, and that's exactly where he showed it in his method. Very different method. Then we tried it in women, and we found that we got when they did clitoral or vaginal or cervical self-stimulation, we got exactly the same region, the paracentral lobule. And notice that this is important, that while they all project to the same region, they project to different regions. And it's known that in reports in the literature that women can have orgasms from cervical stimulation, from vaginal stimulation, or from clitoral stimulation. So each of these regions is adequate to produce orgasm, but this means that a larger region, when they're all stimulated together, you get more neurons, and they describe when in combinations, when these are stimulated in combinations, the orgasms feel more intense and more complex and more pleasurable. Now, and this activity is the hand. That's a hand activity because they're doing the self-stimulation. And serendipitously, we found that if they do nipple stimulation, because we were mapping other parts of the body, we asked them to do nipple self-stimulation. We got activation of the same genital sensory cortex from nipple self-stimulation. And here is the nipple is shown in white, the nipple activation, and you can see that it overlaps with all the others right in the paracentral lobule. And these are some examples of that. We also got activation in the chest area, which is not surprising. But the nipple projects to the genital sensory cortex, which could account for why nipple stimulation is reported as feeling erotic in women. So one question is, does the vagus project to this paracentral lobule? We did vagal stimulation. There's a branch of the vagus nerve that innervates, that carries sensation from this part of the ear, this region of the ear called the sympoconchi. And so when we stimulate it electrically, we did in fact get activation of the paracentral lobule. So that means that vagal stimulation can activate the paracentral lobule, and that may account for what happened in the women with the spinal cord injury. We also found that just thinking about the nipple or the vaginal or clitoral stimulation activates the same region. And this was a big surprise. But we found that the difference between physical stimulation, self-stimulation, and thinking about it was that the prefrontal cortex gets strongly activated in the imagined situation, but not the physical stimulation. We found that in men, we get exactly the same thing. We tried different regions of the genital, different parts of the genital system, and we get they all go to the paracentral lobule, but in slightly different regions. And we also showed by doing rectal stimulation and prostate stimulation. This is I devised a simple stimulator where they press against the rectum and then press harder and stimulate the prostate more anteriorly. And we asked, did it feel different when you push harder? And they had to say, yes, it felt different. And that was evidence that the prostate was really being stimulated. So we subtracted a combination of prostate, when they stimulated the prostate, that's rectum and prostate, we subtracted electronically the rectal stimulation only, and we got the prostate only. So that means that the prostate itself projects to the genital sensory cortex in men. Now that the question is, is it innervated by the vagus? And the prostate has develops from there's a part of the prostate called the prostatic utricle that develops from the Mullerian ducts that produce the cervix in women, in females. The prostatic utricle is called the vagina masculina, a recognition that it develops from the same system. And here is the Mullerian ducts forming the vagina and cervix. And so this is the region of the Mullerian duct vestige that it becomes vestige in the male, and that's the vagina masculina. So if the vagus nerve innervates the cervix, does it also innervate the vagina masculina? And we also found in men that nipple stimulation activates the same genital sensory cortex. So there are other examples of non-genital orgasms. We actually did a study in a woman with a complete spinal cord injury below the neck, and she had orgasms from stimulating her neck with a vibrator. And many men and women with spinal cord injury who I've spoken with said that they have a hypersensitive skin area near the site of the injury that if it's brushed accidentally, it's very aversive. It's can be excruciatingly painful. But if the right person stimulates it in the right way, it can feel orgasmic. There are a lot of other examples in the literature of regions of the body that can produce orgasms. This is published. I can send that to you if you're interested. So in conclusion, when the clitoris, vagina, and cervix are stimulated jointly, the women describe a more intense orgasm, more complex. And that is probably because more regions in the brain, as you see, are activated by the combination of all the stimuli. So, so we need more research as to whether in women with complete spinal cord injury, if they do vaginal, cervical, nipple stimulation and external ear stimulation to stimulate the vagus, and they do the fantasy of the thinking about the stimulation, would that increase the activity in the genital sensory cortex to the point that they would have a more intense sexual experience? And the same is true in men. Maybe the prostate stimulation would activate the vagus. And then if they combine that with nipple stimulation, the ear stimulation, and fantasy, that might also intensify a sexual response. So thank you for your attention. Sorry, I went a little bit over time.
Now, please welcome Mark-Lee Alexander. She is a physician, practicing physician and president of Sustain Our Abilities, a program that she will talk about, and I think you should check out. Mark-Lee comes with many, many years of experience in researching and treating and educating folks with spinal cord injury about sex, sexual health, sexual pleasure. So please welcome Dr. Mark-Lee Alexander.
Hi, everyone. I'm Dr. Mark-Lee Alexander, and I want to thank you for listening to my presentation today on sexuality and spinal cord injury. And what we're going to be doing is, interestingly, going from the beginning to the end. I'm going to be trying to share 30 years of work in sexuality and spinal cord injury in 15 plus minutes. So I've been a researcher, I've been a clinician, and I've been an educator. And I want to thank you again for being here, and also thank PVA Education and Training Foundation, who have funded my newest work in sexuality and spinal cord injury. I want you to remember the word compassion. It is an acronym for what is important in terms of sexuality: communication, owning up to our childhood, masturbation, learning how our bodies work, our partners, our age, stopping polypharmacy, sustaining successes, investigating options, optimizing our future, and being natural. So communication is key when we think about spinal cord injury or anybody in terms of sexuality. Communicating with yourself, with your partners, and your healthcare professionals is an important thing to think about. Also, owning up to our past. Many of us have issues when we're children in terms of sexuality. Was it openly discussed? Was it hidden? Were you abused? Do you have a primary sexual dysfunction? How old are you? What is your sexual experience and age? Are you from a sexually liberal or repressed society? And is your current societal role different than before? And does that impact your sexual relationships? What about pre-existing conditions? In addition to pain, depression, prostate problems, menopause, there's diabetes, high blood pressure. A lot of things can impact your sexuality. So we've got to consider what happened before your spinal cord injury. Next, we need to understand how your spinal cord injury affects your body. So I recommend to everyone after injury to try masturbation. Now it's even easier because there's Bluetooth toys available. For instance, the Max, if you can get some type of erection, you put it in this device and it will provide a suction and vibration mode. And then Nora is a vibrator and a dildo. Both can be used alone or with a partner because they're Bluetooth. Based on your level of injury, we can think and almost figure out how your injury should impact your sexual responses. Okay, if your injury is at T10 or above and you have spasticity, you're likely going to have reflex erections or lubrication from touching. And orgasm should be possible. Psychogenic arousal, or arousal that goes from your brain to your genitals, is based on how much sensation you feel between T11 and L2. Now, if your injury is below T10 and you have decreased sacral reflexes, then you have decreased reflex erections or lubrication. In only one group of people, those people that have complete lower motor lesions affecting their sacral segments, these are the people that are having more difficulty, I've seen, having genital orgasms. We do have a thought of what you can do, though, and that's to try non-genital orgasms. And then psychogenic arousal, again, is based on that T11 to L2 sensation. And you're probably saying, so what's that? Well, it's the sensation that you feel on the surface between your belly button and your pockets area. So this is about arousal. Well, what about orgasm? Well, I've actually done research in a laboratory looking at about 100 people with spinal cord injuries as they self-stimulated to try and have orgasms. And in this group of women and men, about half could have orgasms in a laboratory. It took longer than before injury. Orgasms felt different, but my blinded co-investigators could not tell which orgasms were described by people with spinal cord injuries, with complete injuries, incomplete injuries, or able-bodied people. And blood pressure, heart rate, breathing responses were very similar to able-bodied people. So when you look forward in 2017, I did a study and we looked at all the studies that examined orgasm and spinal cord injury. And actually more women than men have been studied in terms of orgasmic capacity, about twice as many women as men. And about 56% of sexually active women say they have orgasms as compared to men. And if you put everybody together, it's about 52%, or more than half of people that are not being treated say they have orgasms after spinal cord injury. So to me, this is really good news, because if 52% of people can have them and nobody's treated them, then there's room for improvement. In fact, women have multiple orgasms after SCI. We do know that orgasm and ejaculation are not the same, and you can have one without the other, but male research is biased towards ejaculation. Again, blood pressure doesn't appear to be excessively elevated, and the good news is when people ejaculate, they have decreased spasticity. So if you have a spinal cord injury, how do you wrap your head around this? How can you have an orgasm if you can't feel on the surface? Well, the key is that orgasms are internal, not external. Orgasms are a reflex response. What happens when you have an orgasm is there's increased sympathetic response. Your blood pressure, your heart rate, your breathing go faster, and then it crescendos. And then there's a parasympathetic response. So we have to put this information together about increased sympathetic response with the fact that there can be non-genital orgasms and that you can have an orgasm without ejaculation. The other thing that does happen with orgasm is while there is increased activity in the brain, it's really at the base of the brain, in the more primitive part of the brain, the brainstem. And then you see the cerebellum being active. Actually, the part of your brain, the frontal cortex, has decreased activity. So in some ways, I think of it as it's a good way to shut your brain off, have sex and have an orgasm. Well, we talked about the M, right? Masturbation and how injuries affect responses. Now, what about partners? Well, having a partner is very important to people's sexuality. And it can be a significant concern for people in a chair. I do know that many of my couples I've seen, it's not the person with the spinal cord injury that doesn't want to have sex, it's the partner. And so loneliness can be an issue. And this woman's back says, I've never been kissed. It's not that I don't want to, it's just that nobody else does. In addition to the issue of partners, there's the issue of relationships. Where are you in terms of a relationship? In particular, the issues of people that are LGBTQ, these issues haven't been addressed. And I'm happy to say that our show that I will mention, Everlasting Love, on this show, we have addressed two issues recently in terms of partners. One is people that don't have a partner or don't feel comfortable having a partner. And we have 2 episodes coming up on surrogate partner therapy. And the other issue is if you are LGBTQ, what are the special issues you must deal with in terms of spinal cord injury? Also, as we start this discussion, how do health professionals let people know it's okay to talk about these things with me? Really great episodes. So past the partners, what about your age? Well, I'm older, you're older. Everyone in this room is older than they were 5, 10 years ago. And as we get older, our bodies change. We go through menopause. Our erections take longer and are softer. Lubrication is less. Energy for sex, desire decreases. And maybe you don't want to just have sex any time of the day anymore. It needs to be planned. With age, just like having a spinal cord injury, we do get more practical. But we need to appreciate it. In fact, for women, sex can actually get better as they get older. The S, now we're to the S's. Well, the first S is stop polypharmacy. As we get older, we go see doctors, and doctors prescribe drugs. Medications are probably the biggest cause of sexual dysfunction, in my personal opinion, for people with spinal cord injuries. Narcotics, antidepressants, antispasticity meds, antihypertensives, bladder meds, anti-seizure meds. Some of the names: baclofen, Prozac, gabapentin, pregabalin, Lexapro. These drugs can all cause sexual dysfunction. So if you are taking one of these, I encourage you to talk to your healthcare professional and say, you know, can my medications be causing a problem? Can we adjust the way we take these drugs? Do I really have to take it at this dose? Can I decrease the dose? Wean down on medications before starting new ones. And if you do wean down and you've got a success, or even if you were successful with not doing anything, be happy, sustain your successes, celebrate, share. Even though you share and you're happy, keep thinking about it. Investigate options to increase intimacy. What's intimacy? Well, it's romance, right? Lighting candles, going out to a nice dinner, getting dressed up, doing the things that make you feel intimate and your partner. And in terms of options, there's so many options out there. Lubricant, vibrators, penile rings. These used to be prescribed all the time. Well, now you can find them in Walmart or CVS, and they're soft and pliable, and they even have little vibrators attached. Now, the thing is, if you can have an erection, you can use the ring, but you've got to be careful not to use it more than 30 minutes, or that can cause problems. Also, there's the PDE5 inhibitor drugs, and you see them here. These drugs have been shown to work pretty well in men with spinal cord injuries, 75 to 85% of the time, but they can't be used with nitrates, and they are expensive. So again, I'd say stop drugs that are contributing negatively to the problem before starting new ones. There's big toys, just like there's little toys. Check things out, look online and see what you can find. These devices actually make it easier for people to move when they're sexually active. And going back to women, what is there for women in terms of sexual responses? Well, I did do research on Viagra and different feedback mechanisms to improve arousal. The third option we will talk about, because that actually was the most successful in terms of women's sexual function. If we think about women in general, though, there's actually been a couple of drugs that came out in the past few years. I'm not going to talk about the first one, flibanserin, but the second, Vyleesi, interestingly, just like flibanserin, it's FDA approved for a very small group of women, premenopausal women, low sexual desire, not because of medications, medical or psychiatric conditions, or because of relationships. So we get into this very small subgroup of women. In this group of women, they can take an injection 45 minutes prior to having sex, and they must not have high blood pressure or cardiac problems. The injection will cause increased desire, decreased distress, and as opposed to flibanserin, this one can be tried if somebody does drink alcohol. But you can see it's a very small option. So in terms of the devices that I talked about, both the Ferticare and the Eros device, which is on the left here, work by stimulating reflexes. This obviously is used, this is a soft tip we put on a male vibrator, which will increase sacral reflexes. And this is a clitoral vacuum suction that will increase clitoral reflexes. These both were shown in a clinical trial to improve women with spinal cord injury and MS's ability to achieve orgasm. And the Eros device worked 3 months after and continued working, even if you hadn't used it for a month. Midodrine is a drug that is used by probably a lot of you watching this lecture to increase blood pressure. Well, in fact, midodrine has also been shown in men in France to improve the ability to ejaculate and to improve the ability to have orgasm. So my thought is, if it works in men, it probably would work in women too, but this is something that needs to be studied. Testosterone is certainly been out there for a while, and when you do take testosterone in men, you need to have your levels checked. It's also used off-label in women and does improve sexual desire and the ability to have orgasm. Finally, just to review, vibrators can also be used in men. There's many types. While they're primarily used for fertility, they also do work to improve erections, ejaculations, and orgasm. And then there's other means of stimulation. Really, when you're investigating options, it's the sky's the limit, but it's got to be balanced. It's got to be what works for you now, how safe is it, and what is the evidence. So you've got to be careful with any of these means. After you've investigated options, though, don't give up. Optimize your future. Be open to creativity. I'm not advocating that people necessarily go out and get harnesses by any reason, but what I'm saying is be open. And then finally, getting back to where I think we need to begin, and that's be natural. Let your love flow and be nice, because niceness is what's going to get you that partner. And when I say be natural, I want to remind you again, think about the issue of mindfulness. When you're having sex, you don't want to watch yourself have sex. You want to just be in the moment. So that is a key issue in terms of sexuality for anyone, not just people with spinal cord injuries. As I end my talk here, I'm at my time limit. I encourage you to check out Everlasting Love on the Sustain Our Abilities YouTube channel. We will be having some live Q&A shows coming up in December, January, February. And I also want to say thank you again to PBA for funding this show. And I look forward to talking to you later and getting into the Q&A session. So see you soon.
Okay, welcome back, everybody. I'd like to introduce you to Barry, Like, and Mark Lee. Thank you all for being here. Thanks for your presentations. I know we've got a few questions up here, but I want to start with one that we were just actually talking about. All of you recognize that sort of one theme here, and particularly that comes out very much, Mark Lee, in your presentation, is there's a lot more potential here than I think people may both realize themselves and also have been told. So let's talk about that a little bit. When you say there's more potential, what does that mean? What does that require from folks with SCI?
Well, we have lived in a society that is really kind of anti-sexual for the past few years. And actually the way healthcare is structured, doctors don't really think about sex when they work with people. And this is not necessarily even people with spinal cord injuries, but in general. And so when someone has a new spinal cord injury and they go into rehab, in many of the rehab programs, there's really not information given out about what people's sexual potential is. And a lot of times when there is given information, it's not very accurate. It's not really up to the minute. The other thing is a lot of times when people are going through life, we're focusing on the spinal cord injury, but we're not focusing on everything else that has happened to the person with spinal cord injury since their injury. So you might have been given baclofen. You might have had some pain. So someone gave you gabapentin. Someone put you on SSRIs or serotonin-specific reuptake inhibitors for depression. All of these things can negatively impact on someone's sexuality after spinal cord injury. So the way I look at this is what we really have to do is look at the person, make sure they understand how their life in general and their spinal cord injury may be impacting their sexuality, and then go from there. Get rid of some of the offending agents. Try to maximize your potential. Learn how your body works. And the research does show, if half of people with most spinal cord injuries can have orgasms, and that's without people being treated, well, what if we actually give people help? What if we actually train you to become more sexual? And, just like we do bladder retraining, we do bowel retraining. Why aren't we retraining sexual function? So I think there's a lot of optimism that we can have. And I would encourage people, please check out Everlasting Love, which is a series we're putting on now on the Sustain Our Abilities YouTube channel. We actually have a panel of 5 people, and we've talked about many sexuality issues, from issues in LGBTQ populations to understanding how sexuality works, Spanish issues, looking at surrogate partners. So I would really encourage people to check that out.
Great, thank you. So kind of along those lines, there is a question on the chat board from Jason. Maybe I'll address it. I mean, I address it to any of you, but Jason says, how can the dorsal penile nerve be activated in humans? And along the lines of exploring, says, well, anything that we can try, sort of DIY efforts in that spirit of openness. Like, Barry?
I can start. I mean, we actually selected the dorsal penile nerve as our target because it is relevant to human function. Stimulation of the dorsal penile nerve in humans will stimulate ejaculatory reflexes. And we therefore think it is just a nerve that will kind of carry the most relevant sensory information to trigger. Now, obviously we stimulate the nerve very isolated in a very controlled experimental, setups. Okay. But there must be ways to stimulate this. We stimulate the nerve actually at the base of the penis. So by stimulating the penile structures, all the sensory information will go through this nerve. But I think Markela can also speak to this as well.
Yeah, you can stimulate your dorsal penile nerve by masturbating.
Yeah.
You can have your partner stimulate it. There is going to be, basically the nerve is still there. You might have a complete spinal cord injury, but just by, using a vibrator, using a hand, using the suction device I showed in my presentation, people do try some e-stims. I'm not sure if that was one of my slides or not, but any of those means will actually be stimulating your nerves down there. Just like if you get your reflexes tapped, you'll have a reflex function. That's how you're stimulating those nerves.
I do want to add, though, that we do have some evidence, although it's unpublished, that the dorsal penile nerve itself has also altered as a result of chronic spinal cord injury. And so therefore, the stimulation of the nerve may need to be altered, different from that in an uninjured individual. And there's evidence for that also, as this nerve is involved in bladder function too. And there's also evidence there that stimulation of the nerve may need to be done differently. But most of those findings are unpublished. But so that is something to keep in mind, that the sensory stimulation may not work in the same way because the nerve itself may have also undergone some molecular changes.
I'd like to add something.
I want to just respond to is, when people stimulate themselves to orgasm, it does take longer after spinal cord injury. So that goes directly in line with what Like is saying. Sorry, Barry.
I'd like to add a couple of points. One is that in a paper that we just published this year based on new functional MRI findings, we have evidence that not only does the dorsal nerve of the penis, which innervates the skin of the penis, not only does that carry sensation from the penis, but there's a probably the pelvic nerve as well, which is the parasympathetic nerve on the output side that produces the penile erection, but it has sensory components. And when we, so deep stimulation, squeezing, pressure stimulation, in addition to the skin stimulation, the pressure stimulation will probably stimulate the pelvic nerve, and in addition to the pudendal nerve, which is the dorsal nerve of the penis. Because what happens is if we get two different distributions of activation of the sensory cortex. If we just do if the men just do light penile skin stimulation versus if they squeeze, like two different regions, which means that they're probably two different nerves. And if the dorsal nerve of the penis is compromised by the spinal cord injury, it's possible that the pelvic nerve input could be spared to some extent. So it would be worth trying not only just skin stimulation, but also deep squeezing. And also, something that we have found in a study with rats with repeated vaginal stimulation is that we get evidence of sprouting of the genital of the pelvic nerve entering the spinal cord. We've published this a couple of years ago, that this sprouting and recovery of function with repeated stimulation of the vagina and cervix in the rats. So it's possible that repeated stimulation might have an effect in men of possibly inducing sprouting, which is what we found in the case of the rats in the spinal cord.
So the next
synaptic connections.
So the next question I have, and is reflected on the chat board in a couple of questions, is given all this stimulation and pressure, what are the concerns about autonomic dysreflexia in both men and women? Lana asks, while orgasms may be possible, can you please comment on the risk of AD and sort of the potential for worsening health outcomes? Nancy asked this question as well, and even a message I got from a text, that there are concerns about AD. So what do you have to say about that? Any of you?
I'd like to go first. In 100 people with spinal cord injuries I had in a laboratory, in my research, I never had anyone with extremely elevated blood pressure. I know people, then there's a lot of talk about dysreflexia being similar to orgasm. Well, when able-bodied people have orgasms before your injury, when you had an orgasm, your blood pressure went up. Everyone's blood pressure goes up when they have an orgasm. So in terms of having sex, the worst thing is if you go and you have sex and you are thinking about, am I going to get dysreflexic? Am I going to get dysreflexic? You know what? You're never going to have an orgasm. When you want to have sex, you've got to focus on the sensations in your body. You've got to not think about, am I touching my pelvic nerve or my pudendal nerve or this? The key is good sex is mindfulness and really focusing on the sensation. So what I would do is be sexually active. If you do end up having a headache, well, then stop. Stop what you're doing and take your time. Remember, dysreflexia occurs above the level of T6. There's many reasons for dysreflexia. And if you're going to have problems with dysreflexia, it can also be because of those many issues. And in my studies, everyone was given the opportunity to use a vibrator. Now, dysreflexia is definitely an issue when people are having ejaculation procedures, and Like may want to talk about that. But during orgasm, it's actually not, it's not really been shown. There was one case where Barry and I had a woman with high blood pressure, but I never had that repeated. So I don't consider that an issue.
Like?
I don't really have much to add. It's just what Michaela said. Michaela says it's definitely a problem in men. And so in the animal models, we therefore focused on the lower levels, the mid-thoracic, and we don't go higher up because of that problem. It's very well documented clinically. And so I decided therefore not to focus on that initially for our initial studies.
Okay. Barry, something I wanted to bring up that you had mentioned in our previous conversation, kind of as it relates to men and orgasm in men. You're very interested in studying what was towards the end of your presentation, the link between your discovery in females with males and the prostate. Can you elaborate a little bit on what you're very interested in, and particularly from the audience?
Well, there are two men. I've heard anecdotal reports from two men with complete spinal cord injury, and this was about above T10, that they had no genital sensation and no other sensation below the level of the injury, no movement, but they could feel their prostate. That was the only thing that they could feel when they did the bowel procedure, bowel management. So I think it's a very interesting possibility that it is via the vagus nerve because of the embryological origin of the innervation of the prostate. So if there are any men who have that kind of experience, I would really like them to let me know, and if they'd be interested in doing a study of doing the stimulation in the scanner and doing a functional MRI. I think it would be very important to establish whether the vagus nerve carries prostatic stimulation and whether that can be in some way modified to be pleasurable.
I would make one comment, Barry. There is some work on anal sensation and fMRIs in terms of looking at spinal cord injury and completeness of injuries. So there have been some fMRI studies looking at that.
I'd appreciate it if you could send me the references to those, because I'm not aware of that.
Yeah, definitely have been some.
So let me ask you, let me depart a little bit and ask you sort of a more global question over the years of your research. Have there been challenges in getting some of this research funded, peer-reviewed, published? Barry, you've been at this a long time, and Mark-Elise, I mean, all of you have been doing this a while, and this is of very high importance to many folks in the SCI community. Can you comment at all on, maybe historically what's happened? There's not a whole lot of people doing this research, difficult research, difficult to measure, difficult to model. How do you see this going forward in the future? And are there any folks doing this research coming up that you're hopeful about and optimistic about?
So I'm actually involved in a study that's going on now in Australia, in Adelaide, where Ryan Doig, who is a postdoc, is doing a replication of a study that Craig Nielsen Foundation funded that I did a few years ago. And it's looking at spinal fMRI in women with complete spinal cord injuries in an fMRI machine. So there is some research going on, at least in terms of things I'm aware of. I think we need to be a little more aggressive in terms of doing clinical trials per se. I really think midodrine would be something to test in a clinical trial. But I think the key is that before anybody gets involved in this kind of research, they've got to go through a structured program where other sources of sexual concerns are also treated. And I just want to say, there's also another resource I wanted to give people. I wrote a book a few years ago called Sexual Sustainability, a guide to having a great sex life with a spinal cord disorder. And it goes through step-by-step spinal cord injury and how sexual response is affected, all the medications and everything. And it's on Amazon, and we make it free sometime. It's like $5, so just a comment.
Can you, when you have a chance, put a link in the chat, in the live chat, so if you find that. Lee, Barry, any comments? In response to my global
funding for the basic science projects has definitely been really tough, and it's been tough just for basic science of sexual function, period, like, independent from spinal cord injury. And in fact, I think it's through the advocacy of the spinal cord injured community that there has been more funding for this topic, by talking to the Craig Nielsen Foundation, by talking to funding. I know you've been very involved at the state level as well. Multiple states now have programs too, with being told to look for these specific topics: sexual function, bladder function, bowel function. So there I do see some, I'm a little bit more optimistic. But I'm a real basic scientist. I really believe in the strength of basic science. We did the discovery of the spinal ejaculation generator now several years ago. That was a very impactful discovery that has gone into many different directions and has influenced clinical treatment in other areas, not spinal cord injury related. But I don't really see anybody else who's like really tackling this issue at that very basic mechanistic level. And I do think that is really important. So optimism on one end, not so much optimism on the other side.
Okay. Barry?
Well, I think maybe the attitude is changing a bit through, for example, I mean, your current symposium, because I've had trouble in the past. It's been very difficult to get funding for sexuality research from government or from private foundations. They're very reluctant and nervous about funding research on sexuality. But I think maybe it's changing. And you know, what I'm hearing, it sounds optimistic. So we're gonna just have to keep trying. You know, I've had trouble with the government agencies, with the Veterans Administration, feeling nervous about doing sexuality research. You know, the people working in the field, the MDs working with people with spinal cord injury, with sexual problems, they feel nervous about getting, you know, doing the research or supporting the research. That's been my experience.
So the openness that Mark Ali was talking about is not just for people with spinal cord injuries. It's everybody, and it's culture wide. So listen, that's all the time we have. I do want to wrap it up. I want to ask each of you. There's a couple of more questions on the live chat, not in this Zoom chat, but in the live stream. And if any of you would be willing to take a look at those and maybe answer them, that'd be great. And again, for everybody listening, we will have a breakout session later on and sort of have further discussion about this for those that are interested. Thank you so much for your presentations.
What time does that start?
That'll be right around 3:15 Central Time, 4:15.
Okay. 4:15. Okay.
So thanks so much, everybody. Really appreciate your time.
Thank you for the invitation.
Thanks.
All right. Okay, so we're back, and maybe an appropriate pivot. It's a little bit of a stretch, but I think Like kind of spoke to a little bit of why we wanted to do this next spotlight. Like mentioned, you know, there's been a shift in thinking because people with spinal cord injuries and advocates have been speaking up. And speaking up in particular about living with spinal cord injury. And in many cases in our legislative efforts, opportunities to talk to legislators about things like sexual function. I'll just really quickly say to Mark Ali's point, I think Pete and Jake have heard me say this before, but a particular legislator in a particular state where we were talking about some folks recovering sexual function and the ability to orgasm after years and years of complete paralysis, and a legislator held her finger up and said, I didn't need to hear that. Would be a kind of an indication of Mark Ali's point about the need for openness. So welcome, Jake. Welcome, Pete. Jake's our Cure Advocacy Network Manager. Pete's an advocate in Ohio. Welcome, guys. Why don't we get started?
Sounds good. I just want to say hello, everyone out there across the world. Thank you so much for attending our symposium. I hope you guys are learning a lot. I know I sure am. And Peter, thank you so much for coming on and sharing your story with us today. And before we jump in, I just want to share with the folks on online, a little background about where Ohio sits in the whole Cure Advocacy Network process and plan that we've developed over the years. Peter Knoll is one of our Gold Star advocates. We have many Gold Star advocates across all of our states that we're active in, but Peter is definitely one of those guys. So Peter and a handful of other very dedicated advocates have worked several years through the legislative process, going to the Capitol, meeting with legislators, getting a bill drafted, doing the whole rigmarole. And long story short, they have been able to secure $3 million of funding under the Office of Higher Education. And now they're actually in their second round of project reviews. And Peter, I want people out there to understand that Gold Star advocates like you are not born, but they're made. Because I know it can be intimidating for people to, stand up, take the leap, and volunteer. But you're just a regular guy who stepped up to the plate. So can you share a little bit about how you found U2FP, how you got connected with the Ohio Cure Advocacy Network?
Okay, well, my background is maybe a little different from some others because I was injured. I had a C4, C5 incomplete injury 16 years ago as a result of a motorcycle accident. And really, I didn't get involved with the SCI community at all for about 10 years. I was focused on work activities. And then I got a few less hairs, a few more gray hairs or whatever, and decided that it was time to get involved. And I started doing some mentoring work with the Reeve Foundation, became a certified mentor with them. And then I was invited actually to join the Unite to Fight Paralysis family by Ian Burkhart, who many of you may know. And I've always lived my life by the simple mantra that whatever activity you should strive in life, in a job, to leave it in basically a better shape than when you started. So if in some small way I could contribute to the furthering of SCI research, then that was something which was worthy investing some of my time and effort.
And I just want to remind everyone out there, please submit your questions to the live feed. I want you guys to ask questions during our discussion today. I want you to pick Peter's brain because he's got that experience under his belt. One of the most important aspects of what we're trying to achieve with the Cure Advocacy Network, besides raising these millions of dollars for research, is putting people in the SCI community at the decision-making table. And we've, in Ohio, we're on the back end of it. We've established the funding. We've got this advocacy or advisory board set up. Peter's on the board, and he's actually the co-chair now with Dr. Phil Popovich, which is amazing. Can you discuss a little bit what is it like being on the review committee? What is it like being the co-chair on this review committee?
Sure. Yeah, I mean, I think you said in your introductory remarks that sometimes people feel a little daunted by some of the technicalities of the research, and they're concerned about they won't understand it. Maybe we can discuss that a little bit later. But I mean, I think you really just got to jump in, and with my experiences, as Matthew on his introduction, we've got 6 of us actually who are community advocates on the review committee, and all of whom were very intrinsically involved in getting this funding from the start. So we were all involved in the first round of funding, which was 2 years ago. And that went pretty smoothly. And as you had said, that the funding is through the Department of Higher Education in our case. But we did have some feedback how we thought it might be improved. And so now being a co-chair, that's given me the opportunity to to push to make the process even more representative. And anybody that knows me knows that I'm not shy about speaking my mind, and I'm kind of like a terrier. I get at it until I get to where my objectives are. Hopefully that's beneficial.
And now you're on the second round of funding review projects. Can you talk a little bit about working through the science review? It sometimes it can be intimidating for people if they don't understand the science, having to review 4 or 5 projects at a time, but you develop these relationships with the scientists and researchers on the review board. Can you talk a little bit about that?
Yes, I mean, you're right. It can be intimidating, and as I said before, you've really just got to jump in. And I've reviewed several now, and still, some of the real technical stuff goes right over the top of my head. And I'm an engineer, so I'm a little bit technical anyway. But what I have found is that, well, one of the big benefits that we found with the first round of funding has been the progress reports and the sit downs with the scientists, so that they have an opportunity over half an hour of discussing where they're at, what's some of the problems they've incurred. It's an opportunity for us to learn a little bit and to provide some direction, but also if we don't fully understand something, it's an opportunity for the scientists to explain. And what we found is that generally they are very good at doing that, expressing complex ideas in layman's terms. And really, when you think about it, they have to be good at that, because if they can't explain what they're trying to achieve, they're not going to get funded. So that's the bottom line.
Yeah,
and really, I think with having these frequent meetings has developed a kind of team spirit. So it's not them and us so much as we're all on the team, and we learn from each other.
Exactly. I've been sitting in on those progress report meetings that we've had over the course of the last several months from that first round of funding, and I think it's really great. It's a give and take, a feedback loop of the scientists telling how their progress are going, and then the handful of advocates on the call are able to give a little feedback, give some critiques, ask questions, and help guide where that those projects move forward. And on every single call we've had, every scientist, every researcher has been so thankful for those community comments and feedback to help them ensure that their projects are going in the right direction to actually help people like us in the community. So yeah, I think you're right. It is a community. Like, it's not us and them. It's a community.
We had Jake Chafin on yesterday, and he said the same thing with his experience at Drexel, that the scientists are very receptive and appreciative of our input. And I think some of us maybe have been surprised, thinking that there was no way that us mere mortals could change the direction in which some of these scientists were thinking. But that lived experience is useful input for them, and some of them just haven't had too much of that.
I want to pause 1 second. Matthew, are we getting any questions rolling in, or anybody?
Let me take a quick look. I want to say one thing quickly, just so folks understand. Yep, we do have one. Thanks for all your efforts in advancing research. Do you have any requirements for researchers to share the results broadly with the community, quote unquote, for free? And I'll say one. I'll kind of answer that a little bit. So each state's been a little different, and what Peter and Jake, and that's actually what I wanted to get at, is they're talking about is there's the review process where the scientists and clinicians and people with SCI review scientific proposals, make recommendations to the state. what Pete and Jake were talking about is that after the fact, for those who've received grants, we've helped to organize, and it's not mandatory, but everybody has done it. We have organized these calls with the advocates to say 6 months, 9 months later, okay, how's the project going? Where are you? Do you have any questions for us? We'd like an update on what's going on. And so far, everybody has graciously given us plenty of time to do that. In Minnesota, we actually have written into the program that there be a symposium every 2 years. And COVID put a wrench in that. But the idea is that there's an open symposium. Everyone who's received a grant is expected to present a brief update on their research, and it's open to everyone. But I think maybe Nancy's getting at a question that we toss around a lot, which are these add-ons that we start thinking about. Okay, how can we make this better? How can we improve? How can we improve the relationship? So comment, you guys.
I think one thing I would add to that is, one of the reasons that the dialogue between the advocates and the scientists is as good as it is, because there's an understanding of confidentiality. And sometimes, some of this is cutting edge work. It's not published. It's not ready to be published. There are some collaborations with other entities which are not public knowledge. So yes, we want to disseminate information as soon as it's fit to be disseminated, but the relationship only works if confidentiality is respected when it's necessary.
Great.
How are we doing on time? I've got a few other questions. If
we got about 2, maybe 3 minutes. Well, go ahead.
So Peter, I would like if you could give any words of wisdom out there to people who maybe are not connected to a cure advocacy network in a state where a CAN doesn't exist yet, but they want to join the effort. They don't know how. They don't know exactly what to do. If you have some words for them.
Sure. I mean, if you'd like to get involved, certainly I'm sure Matthew would love to hear from you. If you'd like to hear more about, personal experiences, I'd be delighted to, talk one-on-one via phone or via Zoom. So you just get in touch with me. But the bottom line is, just jump in. Don't hesitate, because you're never going to achieve what you want to achieve if you don't get started.
Let me pipe in really quick, just a little logistic thing. That's one of the downloads that I mentioned early this morning in the remarks, and then even yesterday, to go download our advocacy toolkit, download the SCI constituent flyer, where you can click the link and sign up. And this goes for everybody. That just doesn't mean people with SCI. If you're a researcher and you think this sounds like a great idea, or you're a researcher that's in Texas, Wisconsin, or Colorado, where we have active efforts, we would love your support. We need letters right now that we're preparing for those efforts. So please go and download those. And there's plenty of feedback in there, like Peter's comments and Jake Chalfin's comments in the advocacy toolkit about, kind of their wisdom and advice. Go ahead, Jake. Sorry, I see you smiling.
Yep, that was going to be my last point. It's saying that same thing, the advocacy toolkit and the consultant flyer. It's like there's people out there where like, okay, yeah, I could talk to a legislator. I feel comfortable doing that. But then there's some people who don't feel comfortable yet. So you have multiple choices for getting engaged. And I just want to remind you guys that your voice as a member of the SCI community is a very powerful tool, more powerful than you realize. So please reach out, connect to us, download both of those flyers, toolkits, and, connect with us, reach out to us, and use your voice to help fight for a cure.
Yeah. And also just one little add-on too. It's not just us, right? There are opportunities within NASCIC. There are opportunities within United Spinal with the Reeve Foundation, Praxis up in Canada. These are step up wherever, roll up wherever it is. If some of the stuff interests you about what we're doing, please join us. But I think the key is this is a united effort across a whole bunch of spaces. So that's really what we're after and trying to provoke. So listen, guys, thank you so much. I know it feels a little rushed and we're a little behind schedule anyway. But Pete, thanks so much for being here. Jake, thanks for talking about the CAN and what we've been doing.
Yeah, and Pete, thanks for being a great advocate and sharing your story with us today.
Thanks for the invitation.
Okay, cool. So next up is a presentation from Florian Sulzbacher at the University of Utah, who's also the founder of BlackRock Microsystems in Utah. And for those of you who know Ian Burkhart, or have heard of Ian Burkhart, you'll get a little snapshot of some of that research. So now we're going to hear from Florian.
Good afternoon. It's a great pleasure and honor to be here. I would like to thank the organizers one more time for inviting me to speak in the context of the Unite to Fight Paralysis Annual Science and Advocacy Symposium. I'd like to speak today about the advent of brain-computer interfaces that in recent years have made significant progress that are obviously providing a great level of hope to many people. And I felt it was appropriate after 2 decades of working in this field in providing a little bit of background to talk about essentially beyond the hype, what is possible today already, what the opportunities are, what are still challenges that are lying ahead. And to do so, really take into account that everything that we're doing has to be driven by the need of the people that are in need of the new technologies and solutions that we're hoping to offer. Up front, need to make a conflict of interest statement. As co-founder and chairman of BlackRock Microsystems, I hold equity in the company. I've also got equity in a number of other startups such as Sentiomet, BlackRock Microsystems Europe, and others. The conflict of interest is managed through the University of Utah Conflict of Interest Management that has oversight over any decisions that could be associated with that. So without further ado, I would like to get started here and really talk about how creating brain-computer interfaces is changing lives today. Let's have a look at the status. The ideas and concepts have been around since I started maybe as a late teenager and in my undergraduate studies, where people have in earnest started putting a lot more effort into thinking about how to design and implement neural interface technologies that would allow sufficiently functional interfacing with the brain and the central nervous system in order to try and restore functions. When we're looking at the status today, there are really sort of 3 different types of approaches. One group is based on devices that are commonly used in many of the epilepsy diagnostics and surgery preparation, electrocortical grid arrays that are implanted and used in a chronic setting to try and record signals that could be used for controlling of external devices. And there's been quite a bit of progress that has been made in animal models, and there are initial efforts towards demonstrating these in patients as well, both in the US and Europe. Probably seen that because it's gone through the press quite a bit this year. The efforts by Synchron's team with the Stentrode, a very, very clever approach actually in trying to use the surgical access that is used in cardiology and placing stents in the cardiovascular system, placing those in the brain, and then using that again to record EEG type signals. The next one is a group of sort of penetrating surface electrode arrays, and in that the Utah electrode array, which was invented by my colleague and mentor, Dr. Richard Norman at the University of Utah, and that has been commercialized through BlackRock Microsystems as the one that, as of today, really has the largest patient count and the longest experience also in patients. Overall, there've been, I think, around 33 implants, and that's starting to grow with more and more players entering the field, the majority of which is using the Utah technology. And to just give you an idea as to the number and frequency of world first or first in human demonstrations that have happened, and that one's been increasing over the last few years. It started with initially just demonstrating that, first of all, an implant is safely possible and that the signals are actually still there. I remember when John Donoghue from Brown University through the BrainGate program started as the first one having the courage to say, I would like to transition from animal models into human subjects with that device technology. And there was some concern as to whether, you know, the signals in Matt Nagel, the first patient that had one such implant, would still be there and sufficient to control anything. Once that was demonstrated, of course, the next concern was, could it even last? Could this be something that, you know, has the potential to be working just like a pacemaker for years and years, safely and effectively in a human subject? And we've made huge strides in that direction. Then, of course, you know, there were a number of other groups, the groups out of Pittsburgh with Jen Collinger, Rob Gaunt, and Mike Boninger, who for the first time then dared putting multiple devices into human brain and adding sensory feedback. And from there, it's moved forward in a number of different areas where people have been able to enhance the sensory perception, demonstrate more and more complex tasks, etc. And all along building sort of a body of data that shows that long-term implants are possible, even re-implants are possible, and that you know, the entire system could become so stable that unlike initially where you would spend a long period of time to get to reproducible signals and you'd have to fiddle quite a bit with the algorithms, to something where normally, you know, within a very short period of time upon being released from the surgery, a subject is able to perform actually quite impressive tasks. Now, the most advanced ones you've seen most recently were demonstrated. There was a Science and a Nature paper coming out of the Pittsburgh and the Stanford groups, one demonstrating the fastest thought to typing or communication interface, in which case it was using actually the patient imagining handwriting and reaching, you know, about 90 characters per minute, which is pretty much close to an able-bodied person, definitely faster than I can use my smartphone with my thumbs, which is remarkable, as well as the sensory feedback that was demonstrated by the Pittsburgh team. But again, there are a lot of groups out there. It's been growing, and it's inspired a number of people to further go into that field. So let's talk a little bit about the requirements. First of all, what's absolutely critical is that all these devices have to be designed to be use case dependent. It has to start with the patient need first, then input from the clinicians working with them. The physiology has to be considered, and all of that is really what is driving a lot of the design. Further factors that have to be considered, and that's really why, you know, this is, as I often say, it's actually a system, and it's a value chain of technology, clinical workflow, and user requirements. And if any of those are neglected, you're not ending up with anything that you could in practice really scale and implement. Starts with a surgery. Obviously, it needs to be efficient, replicable, and cost-effective. Of course, it needs to be safe, but very importantly, it needs to be compatible with existing workflows and training. And you have to be able to make sure that it's a process that can be scaled and translated, so that you don't only have a small number of key opinion leaders, maybe at the leading research hospitals that are able to do that, but that it can transition into the second and third tier of hospitals so that you reach a larger number of people. Then, of course, the form factors and materials are an area that has to be very carefully considered. Implantable electronics that have to become smaller, and we've benefited a lot from the advances in the recent decades in terms of the electronics industry, including the ability to make packages smaller. Software, in the end, and that's no different from your smartphone. You know, nobody really cares an awful lot about the chipsets that are inside, that are the enabling hardware platform. But what you experience is the user interface that gives you value. And so you have to be able to create these user interfaces, have to make sure that, you know, they have elements of, you know, a consumer tool that is practical and easily usable, but it has to also be medical grade software with all the requirements that come with it. It has to allow real-time decoding, leverage AI and machine learning approaches, which are really important. And then finally, there's the regulatory aspect, you know, which includes the clearance pathways, and there are a number of different ways depending on whether you're in sort of more niche applications or larger groups, and whether they're predicates, you can point it or not. So you'd be looking at investigative device exemptions for initial clinical studies, but then humanitarian device exemptions, pre-market approvals, which are sort of the most costly ones. And in some cases, 510K mechanisms may be possible. The breakthrough designation is a very, very important aspect that has, you know, enabled people entering that space to get faster feedback and to potentially accelerate their time to market. We're all very hopeful that possibly Congress may pass the associated reimbursement aspects, but even if that doesn't happen, it still has significant value. And then, of course, reimbursement. Who are the people really paying for it? If you position your devices price-wise so that self-paying may be possible, considering that a severe tetraplegic, you know, will likely spend between $3.5 to almost $6 million over their lifetime out of insurance and family coverage. Obviously, something that gives them independence and allows them to rely less on a support system to possibly re-enter the workplace has significant value to both the insurance, but possibly even employers that may be interested in picking that up. As I said, BCI is a complex system of multiple components. In our case, as I said, is of course the front end electrodes and electronics that has to be able to process the data, wireless links, and then the data analysis that then connects it with sort of an end effector that provides the function that you're looking for. The applications are vast. Of course, the immediate impact is to restore function, and often in the case of those people that have been waiting forever to finally be offered solutions, that includes restoring function in severe niche cases, ALS, severe tetraplegia. But then as a next step, you know, there's the ability to broaden the use cases, to really allow people to sort of talk again, walk again, hear again, see again, increase their mobility and their independence. And then eventually, I believe this can be a platform for use across a broad array of neurological disorders. The market, and I won't go into too many details, is huge, dwarfs the impact of cardiac diseases. And I took some things out here because I couldn't find the reference in time for some of those. But as a platform, You know, it starts with restoring some of that function, but there are opportunities across the board to address, you know, a number of other areas as well, which is wonderful because since these markets are so large, it overall scales, provides more resources, helps make devices cheaper because you're reaching a larger population, and makes it easier to then develop new functionalities and capabilities. The interest in brain-computer interfaces as a tool to restore function, for example, in paralysis, has been skyrocketing. I think actually with Neuralink's recent $200 million raise, the amount of money invested has probably increased even further. There's a number of companies entering that space with very clever ideas, from materials, new software approaches, etc. Quite a few in the concept phase, a growing number in the animal phase. The Stentrode, I think, has been the first one after the Utah and BlackRock approaches that have made it into human subjects. And I think this is wonderful. You know, the more people will enter that space, the more opportunities will be there for patients and people who need it to select the solutions that they're looking for. An important aspect in looking at the brain-computer interface development beyond the existing technology is obviously that, you know, as a next step, you have to go into high-density flexible electrodes. You have to further advance the electronics and wireless communication, and obviously want to integrate, you know, the ability to both record and stimulate. The components that are relevant in that case include obviously the front end electrodes, and again there's a plethora of different solutions that are possible. Then the wireless implant module, and again there's a lot of advances that have recently happened. Some originated in original cardiac pacemaker IPG technology, but there are a lot of advances in terms of ceramic, PMMA, and other thin film based encapsulation approaches, and it'll be exciting to see which ones of those will provide the right solutions for chronic implants that are a lot more capable. A lot of customized electronics are important, you know, reaching lower and lower power, reducing something that in the original stages was the size of a large piece of instrumentation in a 19-inch rack to something the size of your fingernail. And then, of course, the portable interface systems, you know, similar to a smartphone or an iPad that are workable at home and allow easy use by a caretaker or a patient. And again, the entire motivation behind it is give independence, give opportunities back, and you know, allow people to get as much as possible back to a life that many of us take for granted. Thank you very much. I really appreciate your time in this. I hope this was a little bit valuable to give an idea. There's a lot of things we can do already, from restoring certain motor function, sensory perception, often forgotten how important it is. We take that for granted, to have that sense of touch, not only in terms of performance, but for overall well-being. And then, you know, providing those capabilities back. And I think it's here. I firmly believe that starting in the next year, we will start seeing products come out that will be commercial.
Okay, we are back, folks, with Florian Sulzbacher and Sasha Rybczewski. Sasha, some of you may know, is a U2FP board member. He's also a scientist in Kentucky, also has a spinal cord injury. And so just a minute ago, Florian, you mentioned the Society for Neuroscience. You did something kind of unique, where you had folks who had a variety of different implants or interfaces in them, and talked about the impact of that and where the technology is, et cetera. And it triggered my thinking, because some of you who may know, at our symposium in Cleveland in 2019, we did something very similar with many folks with SCI who had a variety of devices implanted for certain functions. And so I bring that up because I'm really curious about the feedback and the response that you got from that. And I kind of as a launch to our conversation or a frame. So Sasha, please take it away, and I'll watch the chat board for questions.
Thank you. Well, I guess let's follow up on that. How was that? Because I know that we have always wanted our voices heard. So I'd like you to kind of reflect what you had just told us a little while ago about what influence that meeting had when you had people in the audience who are actually users of the devices.
Absolutely. So first of all, thank you very much for the kind introduction and the invitation, both Matt and Sasha. It's a real pleasure to be here. And coming back to that, in my case, it's sort of, this entire adventure started about 30 years ago in, working as a teenager with disabled children. My mother was working with tetraplegics as well, and being very frustrated at the state of affairs and realizing that we weren't doing anything, compared to technological advances, which put me onto a long track I won't look at here, that then led to my position at the university here, as well as BlackRock being created 13 years ago. And then the long list of now, I think I've been over 75 implant patients, close to 30, 28 or 29 chronic ones so far. And in 2018, and this is what Matt was referring to, I had the idea of proposing to SFN a panel where, instead of the usual suspects, professors, grad students, and surgeons, we'll have the patients on stage, and we'll have them talk about what works, what doesn't work, what from their point of view should be the priorities. And even if you spend major parts of your life always focusing on prioritizing the patient, and you will have seen it from my talk, it all starts and ends with the patient. First, you need to understand the patient need. Then, because it is a complex system and a value chain, you need to understand the clinical workflow, the surgeon, the EEG techs, the post-surgery support, etc. And you need to make sure that it fits into existing workflows. Rather than fighting against that, you want to work with the system. That you want to make sure that the surgical approaches are so that they work well, that that the physiology drives what you need, and it doesn't turn into a technology arms race. The feedback that we received was really surprising to a lot of people, including myself. And that included things that, for example, as a community, we'd held as morally and ethically right, unless we have demonstrated that a device can last 10, 20, or 30 years, don't put it in patients except for in a study. And we got a lot of pushback. We had people on stage saying, I don't think so. You know what, in my case, even if I had 2 years, 5 years would be even better. But the impact it has on me right now, I would do this any day, and I would do it over again, because it gives so much independence back. It is so important in the state that I'm in. And essentially encouraged us to get going right away, to no longer wait for perfecting our wireless link, perfecting the materials, perfecting this. And to some extent, they're really right. If you really look at innovation in many areas, also medical technologies, they never started with a perfect product. You just need to figure out what is good enough that it's morally and ethically right to get started. And I don't think we should have the audacity to make that decision just alone. I think patients, even though they have a conflict of interest because they really, really want something and they may not understand some of the risks, this is often the justification, or the patient doesn't fully comprehend the risks and they're desperate for it and therefore they shouldn't decide. And I feel they deserve absolutely a strong seat at the table. And honestly, some of the innovation we're seeing today with the first pacemakers, cochlear implants, DBS implants, they would not exist if we always had kept the standard this high up because nobody's there, first of all. I mean, we're a little bit like the Wright brothers with the Kitty Hawk, you know, where it's sort of, hey, it flies for 200 feet. That really helps in a lot of cases already. And then we move on from there.
Mm-hmm. Yeah. And so I guess tomorrow we're going to hear from companies like Anovo and Onward, who are going to be taking these medical devices and trying to put them into spinal cord injured individuals. And you've been doing this for a while. We discussed a little bit, is it really the regulatory blocks and FDA that slow these kinds of things down when you see the results, but yet the patients don't get them, you know, enough, I should say. Could you maybe speak to that? I mean, I will hear about them tomorrow, but just in the context of what you had to go through to deliver your device to people.
Yeah, I won't lie that sometimes it was a pretty stony and arduous path to survive and make it through there. But I think it's been a confluence of things that have helped us. And some stuff does take time. First of all, technology has advanced. Materials have become better, devices have become better, electronics have become smaller. Things we can now run on an iPhone, when we started 10, 15 years ago, required sort of a almost mainframe type computer next to the desk. Secondly, the surgical techniques have improved, the reliability. We've learned, as I said, over those 10 years, a lot of things that happen when you go into more real world settings that allowed us to improve things. And you no longer need 3 people with a double PhD behind a black curtain reworking the algorithms every 2 minutes and keeping it going, but it's actually quite robust. You know, you can switch it on shortly after surgery, after people are out of anesthesia, they have decent control. And then finally, and that is probably back to people like, you know, Elon Musk and Brian Johnson 5 years ago, starting to jump into the fray. The financial markets. I think the regulatory side was not easy, but actually, in fairness, over the last decade, the FDA has been very, very active in working with the community, in understanding the field better, in lowering barriers. And I would argue that the US is probably right now more favorable than Europe in allowing us to launch these things. And I think it's also a question of whether society is ready for these type of things. And, you know, and things have grown. Cochlear implants are a lot more common now. DBS is a lot more common now, etc. So the stigma associated with, you want to put what in my brain? Are you mad? Yeah. And it will never work. It's a little bit like, you know, first pacemakers didn't last long. It was open chest surgery. Today, it's a prophylactic and almost ambulatory. So we see this happening. But the final part that is lodged, I think, is financial markets recognizing that neurological disorders are a far larger field than cardiac disorders. And so people started entering the space, and then with Neuralink and others entering, investing, the money was always there somewhere. It just wouldn't go in there. So when we started, we built the company as supporting the research market because I felt we had to learn and we need to survive. I did not have a Warren Buffett in the family, so we had to very, very quickly be cash flow positive and reinvest. Yeah. And now it's been dislodged. And I would say the more companies enter, the more technologies, and whether it's spinal cord stimulators, brain-computer interfaces, I don't see this as negative. I see this as complementary. I see this as very positive for the patients. And it allows us to create a setting where I think we can really revolutionize the treatment because there'll be so many more options. And then jointly, we'll also be able to make a much stronger case to the payers, whether it is employers, whether it is the insurance companies, etc., to see what value there is in helping people to be as independent and productive as they possibly can be.
So Florian, I want to jump in, Sasha and Florian. Just there's a question here that I think speaks to a little bit of what you're talking about, and it's from someone you probably know, Candace Floyd. What unique challenges does the heterogeneity of the spinal cord injury population sort of present for the pathway of a device development like this? And what are your strategies in addressing that, in particularly the SCI population?
Yeah, thank you. That's actually a very good question. It applies not only to the spinal cord injury, it applies to a wide variety of neurological disorders, amputations, etc. You need a platform. You need a modular system, really, that addresses as broad as possible a range of use cases. A lot of people approach that as looking for the medical device equivalent of a silver bullet, the perfect device. And I don't think it exists. What you need is as I said, sort of like a Lego kit rummaging box of electrodes and electronics and surgical tools and, so, you know, different components that, however, agree on a common standard or interface, so that you can create what Tim Dennison in one of my discussions once called a bricolage of parts, where you go in and say, okay, this use case and this application, let's grab this part here and this part and this part, and they're all robust, and I can build something that works. And another thing that is important, that I think in particular the research community has not sufficiently embraced, design to price is another important component requirements. And I think even in the scientific side, yes, when we do a first in human, we demonstrate, the actual cost of that demonstration is not that relevant. It can be like going to Mars or whatever, but the underlying technologies should be so that what eventually is being built can be scaled in a way that it's not more expensive than a cardiac pacemaker or a cochlear implant. You want as broad as possible an uptake as you can, but it's not one size fits all. You need,
that relates to another question Tracy raised. What about cost? What are we talking about here? And I know in our sort of pre-conversation, you talked about a little bit of, you know, that's a significant driver for you to figure out, even recognizing some folks self-paying. So
yeah,
what are we talking about? What kind of parameters here?
Yeah, I think good markers here are, as I said, cardiac pacemakers to cochlear implants, so a range that is somewhere in the low tens of thousands to mid 20,000, maybe in the extreme case pushing 30,000 sort of for the implant. The surgery is usually at another 20 to 30,000. So you're looking at something that is maybe a combined 40 to 50, $60,000 price tag, which is not small. But if you now look at who's paying for it, that is well within the range what payers are used to pay for similar type devices. The cost, if I remember the numbers correctly, for tetraplegic, depending on what age the injury is happening, is somewhere between, I think, 3.7 and close to $6 million over their lifetime. Some of it borne by the families. It is in a range where if you look at how much it costs just to have a vehicle that is wheelchair workable, you easily drop $50, $70, $80,000 on a van that does that. And if it gives you really productivity and quality of life back, it should be possible, not for everybody, for many people to even make that investment. That's been our feedback from surveys with patients. It should be within the realm of what insurance companies feel comfortable with. If you go into the $100,000, $200,000 range because you argue, well, it should be this valuable, I think we're much better off getting as many people as possible to use it and increase the volume, and that will help reimburse the investment costs. And then there's maybe some hope even working with employers. I mean, if I know what my company pays for special software to enable people for employees, and there's ADA regulations, why not have add-ons that are maybe not regulated, an interface that helps you to run your Excel and other programs very efficiently with your interface, and have that be part of the benefits that your employer maybe covers. I think there are a lot of ways of making that possible. And that means that your manufacturing costs for what you're building, have to be, I would say, a maximum of 20% of what you're selling this thing for.
And they're naturally, if I'm not mistaken, they're battery driven, right? So they're going to be depending on how long the life of the battery is, right?
Well, I think we're also seeing more and more cases where it runs a little bit more like a cochlear implant, where it's sort of an inductive link with maybe a small buffer inside for interruptions, but not something where it runs continuously. So you would have an external battery, with the receiver unit that powers the device. But there are two different approaches. We see some that are battery driven. The drawback is, even with all the reductions in power, that you still need pretty large batteries, and that makes the device fairly large. Very often that means that people then go for putting it into the clavicle pocket or somewhere else and running leads, which tend to break, etc. And so the tendency is to follow more the sort of the CI approach, where it's powered from the outside continuously, but maybe has a supercapacitor or something in that it allows you for a few minutes to be offline while you change batteries or do something. That seems to be a trend that I'm seeing more and more now, because it just allows you to make things much, much smaller.
Well, I mean, Medtronic, I have a Medtronic implant. I mean, they're put into people, and 2 years they last sometimes.
Right.
And people, so I don't think that should be an issue. I don't think people should be worried about that. So.
Can I throw another question in, Sasha?
Sure. Of course.
Jared asked a question, what actions, I mean, he says 3 actions, but maybe 1, 2, can the SCI community do to forward this kind of technology over the next year, 2 years? And then also, what are some distinctions between, which wraps up into another Wolfram's question, differences between, for instance, BlackRock and Neuralink?
Sorry, something just cut off for a second. Can you repeat the last sentence one more time?
Yeah, so what can folks in the community do to help advance this? And then secondly, what would be some distinctions between BlackRock and a company like Neuralink?
Okay, so with respect to the first question, I think you're already doing quite a bit, but as the first devices are coming out, to stay engaged with the growing industry, to clearly voice and communicate what the priorities should be, so that the devices that come out meet the community's needs and don't go sort of parallel to those. I believe we can be mutual allies, working with the payers and clearly voicing that as we seek reimbursement, or making sure that we fit into existing reimbursement codes. And I think the next 3, 4, 5 years, if all goes well, we're planning to go commercial in 2022. So next year, with the first devices that are actually available, we very, very close to launching those. And initially, of course, we want to start carefully to make sure we're not screwing this up, and we're working with the patient communities to very quickly address improvements, needs. We also see this as a platform similar to sort of your smartphones, where once we've established, the hardware, the base firmware and software interfaces with a number of functionalities for communication, controlling of external devices, I really hope that the community will drive and develop new needs and use cases that we can go after. And then others, even with their companies, can go after and say, you know what, I've got an app, so to speak, that once you have the device allows you to do A or B. To the second question, Neuralink, as I said, there's been a lot more activity, and I'm really happy there are more people entering this space. I mean, every company has to respond for themselves, why they're doing it, how they're doing it. On the Neuralink side, I'm not entirely sure what their strategy is. They seem to originally start, and they're notoriously secretive about what they actually want to do. You sometimes hear from people that are leaving, but for the most part, originally they seem to want to go towards sort of an enhancement direction. Now they want to focus on patients, etc. In the end, I think the more of us enter that space, the more opportunities and options there will be for patients to choose from. And so I think it's good for the field. I think this is nothing that I worry about. And one thing that Neuralink can be credited with is raising awareness in the financial markets that this is actually important, and there's a market there, there's impact, there's, you know, a business to be had. And I think we can all be very grateful for that having happened, because it's not only us. Every day I hear about new companies, sometimes software, sometimes materials, a few that want to build different systems at different stages, from concept all the way to, I mean, you know, Synchron is now in the first 2 patients. I think there's another 2 that they just recruited for their interface. Paradromics is making efforts. As I said, Neuralink wants to be in human subjects. And I think the most important part in all of that is, and that's why I mentioned that to you, Matt, as just before we started here, we put an ethics board in place right away, because I don't want us to make the mistake that some of the social media have done, where everybody runs out, this is wonderful. And then 10 years later, when the underlying, you know, when the platform is set, everything is running, then people start worrying about, you know, eventually, as it works, would people use it for enhancement or what, you know, because we transition from really helping people, but eventually you need to be aware of the fact that maybe people that don't need it quite that much may want to have it. And then maybe somebody like first responders in high-risk situations that benefit from that. And it's important we start the discussion, because the worst thing that could happen is that out of a backlash and fear, this entire field collapses. And those people that have waited decades, if not centuries, for those solutions, where we now finally can say, you know what, it's coming out. You can go to your doctor, you can just get one and buy one, or get your insurance to pay for it, are put on hold because we as a society aren't ready. And that is what I hope, that everybody who goes out there is very careful in how they do that they're respectful of what we're doing, what we're trying to do, appreciative of the risks also. We need to do this right. That's the main thing. And that's something where I sometimes worry a little bit about, you know, when Kernel and Neuralink started, I interacted with some people that, that were looking for super brains and whatever. And while that may eventually happen, I don't know how many decades, A, we're not here yet. We're very, very far away from that. B, as I said, it's a technical as well as a societal question. And so.
Okay. One last question, because I think even some of what you said lends itself, and hopefully folks kind of recognize, to a good portion of the conversation we'll have tomorrow about neuromodulation strategies and readiness to the clinic and human studies and sort of larger rollouts. What you just said speaks very much to that, and I think we'll hear some of that tomorrow in the conversation. What would you, I mean, Sasha kind of asked this question earlier, like, what would you say to some of these spinal stimulation companies, having been in this space for a while? What last little sage bit of, not advice, counsel?
I always feel as entrepreneur, you know, you shouldn't give entrepreneur advice to other entrepreneurs. They know well, we all make our mistakes. Now, over a beer or so, I'll gladly change stories and things to maybe not do. I think it's wonderful to see that we're not alone in this and that there are more people going into this. I wish everybody as much success as they can have, because that means if they have success, that means that the people that we want to help receive help. And the rest is just have courage to move forward, but do so responsibly. I think that is the main story. And to some extent, when it rains, bring buckets. It seemed like right now is a phase where the financial markets have recognized it. And there is an element of, if there's enough capital around, I think a lot of the solutions are there, the people are there. The documentation is there now. You remember when, you know, John Donahue first put a Utah array into a patient and people were aghast. It's like, are you mad? It's never going to work. Then when it worked, people say, well, it's not going to last long. Well, it started lasting longer. Then Pittsburgh started putting multiple devices in a patient. And then everybody, including John's lab, went, oh my God, it's all going to come down. Don't do more than one device. You know, and And now we've actually established, we understand how to do it and what the risks and what the opportunities are. And the people in the spinal cord field will have the same thing. And as I said, I see this as synergistically and providing something where over time, maybe, you know, we'll also work closer together. There are aspects that can be done better through the brain, others where, you know, spinal cord stimulators better, even a combination of both with closed loop feedback can have lots of advantages. Sensory feedback, we've done a lot of work on the BCI set that I think can enhance this as well. So we're just at the beginning, which is really exciting, but we're finally out there. And sort of, I feel sometimes like we've now jumped off the 10-meter platform. And now you just have to make sure you're not face plant at the bottom, but there's no going back. We're out there.
Well, listen, thank you so much. This was an incredible discussion for him. Thank you so much. BCI, complex indeed, but the applications seem innumerable. Thank you very much for taking your time to talk with our audience. And you and I should definitely keep in touch as we spoke about earlier. So I'll contact you after this.
Wonderful. Well, thank you so much for the opportunity. Thank you for organizing this event as well. And please count on us to help supporting this. And feel free to have all the patient advocacy groups and others reach out and work together to also dislodge, you know, it makes a huge difference if we jointly nudge the people that hold the purse strings in the direction of offering new solutions. I think that'll be great.
Great.
Well, thank
wish
you.
Wish we could be with you in Utah.
You will next time. Yeah, it's really sad.
We'll be there next year. Yeah.
Wonderful.
All right. Thank you both.
Okay.
Appreciate it.
Thank you. Thanks.
You're welcome. All right.
Well, there you have it. We are over time. My apologies. But I just want to leave you with one lasting or one just final thought. I hope there was we think there was a theme throughout the day. And one small part of it is that there are innovations happening. And at the intersection of those innovations, and I think Florian said it quite well, that the people who live with the injury, the people who live with a condition need to be at the table, need to be a part of the process, part of the conversation. And that, I think, came throughout in terms of the clinical innovations, the sexual function, some of the advocacy spotlights, and now with Florian and this sort of burgeoning technology. So thank you for sticking with us and hanging out. We will now move to, you'll have to leave the live stream, go find the breakout room links, decide where you'd like to go. We'd love to continue to have the conversation, and we will see you tomorrow. Thanks.